Hello, everyone. Good night, good morning, good evening. I don't know where everyone is based at the moment. It's a pleasure to be here once again for this massive event that we have every year. I'm here with Julian at the moment. We are the founders of Everything MRI. For those of you that don't know us, we are around 300 people already. People keep coming, which is great. So just small introduction. We have this massive webinar that we start now. There's a Q&A box at the bottom of your screen. You can use it throughout the whole event. Ask all the questions that you want, and we're gonna use those questions to talk to the lecturers at the end. So Doug, Tobias, Vitor, Bill, Erica, and Manny Canal will all be here for the roundtable, so you can ask all your questions live and they will answer. Today we have a really, really big event, so we have amazing lectures to go through. And we also have two major announcements from Everything MRI. And we'll have, of course, a word from our sponsors. So I will actually start with the word from our main sponsor today, and then I'll pass it to Julian to start the event and everything else. So basically, 𝐂𝐻𝐿 is one of our, if not, if is the biggest sponsor of our event today. They are a global leader in automated MRI caution barriers and magnetic field warning signage, and provide innovative MRI patient pre-screening solutions since 2013. So they've been around for a long time. Their safety offerings include the 𝐂𝐻𝐿, some of you might have heard about it, which is a robotic access control solution which prevents unscreened and unauthorized access to the open MRI doorway, preventing, of course, catastrophic accidents from occurring from projectile effects and things like that. So 𝐂𝐻𝐿 is highlighted as an MRI caution barrier option in the most recent 2024 American College of Radiology manual on safety. And actually, they also pioneered the only MRI handheld patient screener that can instantly identify ferrous and non-ferrous materials, thus preventing, of course, RF burns and reducing imaging artifacts and all of that. So they're also excited to announce the upcoming launch of another revolutionary MRI safety solution, as they call it. So it's the 𝐂𝐻𝐿 Smart Entry in 2026. So I would keep in the loop. So we'll share the link for them so you can see it. And now I will pass to Julian. I think you also have a few things to tell us. So let's do this, guys. I hope you enjoy it. We're here for you. We're here to encourage our community to do more and better. So let's do an amazing event all together. And thank you so much for participating from the get-go. Julian, please take the stage, man.
Well, hello, Sam, and especially hello, everyone. Thank you for being here. We are back to the crime scene once again. And I have to say, it is a pleasure to be back for what is the third annual MRI Safety Forum. And we always say this year will be a little bit more relaxed. It's going to be a chill year, but the reality is that has been quite an intense year for everything MRI. We've been committed to deliver free educational material on almost a weekly basis. And this has been ranged from webinars to podcast episodes and these tip and tricks videos about MRI. But there will be quite a lot to come, and something will be revealed during the event, especially during the roundtable. So try to stay connected until the end. But let's not miss the focus for today. The focus for today is MRI safety. Someone already noticed we have quite an interesting lineup. And so without further ado, let's start by introducing the very first speaker of the day. So the first speaker of the day is actually someone we know pretty well in Everything MRI, and his name is Doug Boyd. I want to welcome back Doug because this is the third time he got involved with Everything MRI Safety Forum. And considering how old is Everything MRI, this means probably we've been relying on Doug since day one. He has been there from the very beginning. So Doug has worked as an MRI technologist since 1992, spending the majority of his career at large institutions. Most recently, he served as MRI and PET MRI supervisors at the Phoenix VA Hospital in Arizona. He's a national lecturer on all aspects of MRI, safety of course as well, and for the past 10 years has taught many students in MRI from a range of schools. I repeat this every event, but for me it's like a quote that I need to kind of like repeat every morning. What Doug always says is that do not put off until tomorrow what you can do today. So Just to start, Doug is going to address a particularly sensitive area of mass safety, namely how to approach safety from a multidisciplinary perspective. I'm absolutely looking forward to hear what Doug is going to say. So from the title, Safety First, How MRI Radiologists Drive Risk Management and Clinical Oversight, I'm very honored to introduce to you the very first speaker of the day, Doug Boyd.
Hi, everyone, and thank you to Julian and Sam for having me on this webinar for the third year in a row. I truly appreciate the opportunity to be part of this important webinar. The topic I'm presenting today is close to my heart because I believe it's time we revealed the essential relationship between the MRI technologist and radiologist. Since COVID, I've heard from countless MRI techs who feel they put into high pressure situations, often expected to make clinical decisions without the appropriate support. Let me be clear, MRI technologists are not medical decision makers. They are the eyes and ears for the radiologist or MRMD. They're skilled, observant, and vital to the safety chain, but they should never be expected to shoulder medical liability alone. I've served as an MR expert in multiple MRI legal cases this year, and the common thread has been MRI techs making difficult calls in the absence of a radiologist or MRMD. That breakdown in communication and support is what we need to fix, and that's the focus of my talk today. So I just want to go over some house cleaning rules. My disclosure disclaimers: the following information reflects my views, opinions, and experience. This presentation content was prepared by me. All information in this presentation is for illustration only and is not intended to be relied upon by the reader for instruction as to the practice of medicine. Any healthcare practitioner reading this information is reminded that they must use their learning, training, and expertise in dealing with their individual patients. This material does not substitute for that duty and is not intended to be used for any purpose in that regard. So let's dive into my agenda. First, I'm going to go over the understanding the safety chain in MRI, the MRI technologist role in safety, the radiologist MRMD's role, shared decision-making and communication, two quick case studies that I'm going to talk about decision-making and communication, and then when the safety chain breaks, radiology pressure points and communication tips, building a culture of safety, bridging gaps, what happens when the chain breaks, understanding MRI radiologist pressure points, and then the culture of safety, the training, the trust and empowerment, and then my closing thoughts and takeaways. So MRI is one of the most powerful diagnostic tools in modern medicine, but it's also one of the most unforgiving when safety protocols are overlooked. From projectile incidents to thermal injuries, MRI-related events don't just impact patients. They reflect breakdowns in the process, communication, and shared accountability. The conversation isn't just about policies or checklists. It's about culture, about the relationship between the MRTech and the radiologist, about how as a technologist responds to uncertainty. Because in MRI, safety is never a solo act. It's a chain. And that chain is only as strong as its weakest links. So let's dive into that. So let's dive into the MRI safety chain. So think of the MRI safety chain, that each step in the MRI workflow, we start with the MRI order. We go to screening, protocoling, positioning, scanning, interpreting from the radiologist. That is the vital link. If even one of those links fails, the safety and success of the entire exam can be compromised. This chain isn't just technical, it's human. It depends on the vigilance, communication, and collaboration between the MRTech and the radiologist, schedulers, nurses, and the referring providers. It only works when everyone is actively reinforcing their part. So what strengthens this chain is intentional teamwork, standardized safety protocols, documented communication, and well-defined escalation paths. Everyone has a role to play, and every role matters. And what weakens this chain is assumption, silence, miscommunication, or complacency. A missed implant, a vague order, a rush screening, these small gaps open the door to big risks. In MRI, there's no such thing as a harmless shortcut. This chain is only as strong as its weakest link. And our job every day is to ensure that these links are reinforced, aligned, and unbreakable. So, what are the MRI technologists' role? So first, they're the first line of defense in patient safety. We are the one who greets the patient, not just as an MRI tech, but as a clinical observer. We assess more than their paperwork. We assess their condition, their body habitus, mobility, anxiety level, and often their mental readiness for the scan. We initiate and own the screening process. We're the ones verifying implant documentation, asking those hard questions, and noticing what might have been missed earlier. We identify inconsistencies, red flags, and anything that doesn't quite add up. And when something is off, it's our clinical judgment that determines what to escalate and how to protect the patient. This work is not just technical, it's professional, clinical, and safety critical. Our awareness and our actions are the advocacy that are often the difference between a safe scan and a dangerous situation. So the radiologist's role, they serve as the final medical authority in MRI. They're not just image interpreters, they're the clinical decision makers. And when a tech flags a concern about an implant or safety, something about on the safety form, a patient showing signs of distress, the radiologist steps in and needs to make that judgment call. Their decisions can include whether the scan should proceed or be canceled, not the technologist. How contrast should be used and dosed, what protocol modifications are necessary, whether if it's an emergent situation and if it warrants an expedited read or follow-up. But here's what often is misunderstood. They don't see the patient. Most of the time, their decisions are made entirely based on the information we give them, whether that's through documentation, a phone call, or imaging markers. They rely on us to catch the red flags, report inconsistencies, and escalate when something doesn't feel right. Without our eyes, your hands, your professional judgment at the scanner, the clinical oversight can be incomplete. And let's not forget, radiologists bear all the medical liability. If an unsafe scan happens or if a patient is harmed due to a missed contraindication, the responsibility doesn't just fall on the MRI tech. It often lands squarely on the radiologist's shoulders. But they can only protect the patient if they're armed with complete and accurate information. We have to stop thinking of radiologists and MRTechs as separate silos. In a high-functioning MRI team, communication is consistent, escalation is proactive, and decisions are collaborative. So here's a practical example. So if we're scanning a patient with a deep brain stimulator, you've screened it, you've double-checked the labeling, but something still feels off. The model number doesn't match the documentation. How often does that happen? That's not the time to shrug it off. That's the moment to stop, escalate, and let the radiologist make the call. That's the link in the chain where patient safety is either protected or compromised. Radiologists need MRI techs to act not just as a button pusher, but as clinical collaborators. The best MRI techs anticipate concerns, bring clarity to the table, and treat communication as a core skill and not an afterthought. So if you ever think your message doesn't matter, remember this. The radiologist may have the final say, but they can't say anything if you don't speak up. So this is where collaboration becomes absolutely critical. The MR technologist is the eyes, ears, and hands at the scanner. We're the one who interacts with the patient, performs the screening, places the coil, sees the patient flinch, notices the tremor. Here's the implant story that didn't make it onto the intake form or the screening form. But the radiologist is the one who bears the medical responsibility, and we have to keep stressing this. They're the final checkpoint. the ones who decided whether the scan proceeds, whether contrast is administered, and whether a questionable device is truly MR conditional or not. That relationship between the MRTech and the radiologist cannot be passive. It's not enough to just send images and hope for the best. The bridge must be active. The MRTech must feel empowered to escalate these concerns. Pick up the phone, pause the study, and just to say this doesn't look right. That's not overstepping. That's professional accountability. And on the other side, the radiologist must remain accessible and responsive. If the MRI tech has to jump through hoops to reach the radiologist, or if they feel dismissed when raising a red flag, the entire safety system begins to break down. This is a two-way street, whether mutual respect, clinical trust, and clear protocols define the workflow. That makes MRI safer, faster, and more patient-centered. So the message here is simple. Don't assume, don't delay, communicate. Because when the MRI tech and radiologist actively bridge the gap, patients don't fall through it. So let's walk through one of my case examples here. So this is a situation that highlights the importance of vigilance and communication in MRI safety. So a patient arrives for an MRI with a neurostimulator, but there's no implant card, no documentation in the EMR. The MRI technologist notices this during the screening process and immediately pauses the study. Rather than proceeding with limited information, the MRI technologist initiates research using all the trusted resources, safety databases, manufacturer websites, or past documentation. Based on this, they've identified uncertainty about the device's MR conditional status. At this point, the MRI tech needs to escalate this concern to the radiologist or MRMD, presenting their findings and requesting a formal decision on how to proceed. The radiologist determines that the scan should not proceed. This isn't clinical decision making, it's clinical responsibility. The MRI tech role is to recognize these red flags, pause the workflow when necessary, and gather that relevant safety data and alert the appropriate medical decision maker, which is the MRMD or the radiologist. Their actions directly support patient safety and compliance with MRI safety standards. This example underscores why MRI techs must be empowered and trained to speak up, investigate, and escalate. Because even though they don't make the final call, they are the first and most consistent line of defense. So let's walk through case example number 2. So this is a powerful example of what a well-functioning MRI safety chain looks like in real time. The patient is scheduled for a routine lumbar MR spine. Nothing in the referral suggests urgency, but as the MR tech positions the coil, the patient begins to report sudden onset numbness in the lower extremities. These are really red flags and neurological symptoms that require immediate escalation. The MRI tech does exactly what they're trained to do. They pause the study, assess the patient worsening symptoms, and notify the radiologist immediately. Rather than continuing with a routine workflow, the team shifts gears. A stat wet read is performed mid-scan, not after the patient leaves the department, but while they're still on the table. The images reveal a acute spinal cord compression, and the emergency surgical interventional team is initiated before permanent damage occurs. This isn't just about recognizing pathology, it's about the communication, action, and trust. This is the power of the MRI safety chain. The MRI tech identifies the red flag. The radiologist responds and reviews images urgently. A critical diagnosis is made in time for intervention. It's not just about technology or training, it's about culture. A culture where the MRI tech feels empowered to escalate and the radiologist is accessible and responsive. This is the definition of patient-centered safety, in my opinion. Communication tools. In the MRI environment, we have multiple communication tools at our disposal, using the phone, PACS messaging, secure texting apps, email alerts. There's many more, but tools only protect patients when they're actually used. What matters isn't the tool, it's the consistency. A quick call, a secure message, a raised concern during the pre-scan prep, these small acts build as a safety culture. Silence, on the other hand, is the single most dangerous behavior in MRI. When something seems off, a vague discomfort from a patient, an undocumented implant, an unclear clinical indication, it's easy to brush it aside and hope someone else will take the action. But in MRI, the moment of hesitation can lead to injury or worse. Technologists may feel unsure. Am I overreacting? I don't want to slow down the schedule, or I might get in trouble. We need to stop and follow that safety chain. So the legal and ethical responsibility. Patient safety in MRI is a shared responsibility. MRI techs are accountable for meticulously following safety protocols, identifying red flags, escalating concerns, and ensuring that accurate documentation supports every decision. Radiologists, in turn, must assess clinical risk, clear implants, determine scan parameters, and make timely, informed decisions. This partnership is not optional. It's expected by the courts, regulators, and accrediting bodies. When communication breaks down, liability is shared. A missed safety step, an undocumented concern, or a failure to escalate can be seen not just as oversight, but as negligence. The strength of MRI safety chain depends on clear roles, continuous communication, and mutual accountability. So how do we improve this link? To strengthen MRI safety, we must move beyond passive communication and implemented structure, proactive strategies. This means starting each day or high-risk case with a brief scan huddle to clarify roles, review implant concerns, and discuss patient-specific risks. It means using implant and device checklists that are verified both by the MRTech and the radiologist before scanning begins. I have used checklists for 30 plus years. I am such a huge believer in checklists. Give it a try. You'll be surprised. So after the scans, especially those with complications, post-scan debriefs help identify what worked and what didn't, so the team can improve continuously. And that's what it's all about. It's all about patient-centered care. Most importantly, we need a reporting culture where MRI techs and staff feel safe to speak up, whether they're raising a safety concern, questioning an order, or simply following their gut. Silence is dangerous. Communication is the only protection. AI, the future of MRI safety. This is entering the MRI space, and it's coming quick, and it's bringing significant benefits. AI can assist with implant flagging, protocol recommendations, and image optimization, streamlining parts of the workflow, enhancing consistency. It will absolutely help. But let's be clear, AI cannot replace clinical judgment. It cannot interpret body language, recognize a nervous patient who says they're fine, or hear a faint burning smell in the scan room. It won't detect subtle red flags, but unexpected skin markings, patient confusion, or coil discomfort. The heart of MRI safety is still the human connection between the MRTech and the radiologist. Real-time decision-making, escalation, observation, and teamwork. This relationship is what keeps the patient safe. AI is a tool in that process, not the foundation. So, closing thoughts. So let's not mistake technology for responsibility. The MRI scanner can acquire images, but it doesn't make clinical judgments. It doesn't screen for safety, and it doesn't escalate concerns. It's the MRI technologist who spots what a form can't say, who sees a nervous expression or a hidden scar, or a hesitation that reveals more than words. It's the MR radiologist or MRMD who weighs the risk and benefit, who makes the tough call to scan, delay, or cancel. But neither role in a vacuum. Safety depends on the link between them. A strong chain built on communication, respect, and shared vigilance protects the patient every time. And again, every link matters. Every scan is a chance to get it right. And that is the real foundation of MRI safety. So let's talk about what happens when the connection between the MRTech and radiologist fails. Most MRI safety incidents and many legal cases don't occur because someone lacked the knowledge. They happen because there was a communication breakdown. It often starts with an assumption. A MRI tech sees an implant that looks similar to the one previously scanned and assumes it's safe. The radiologist is never informed. The scan proceeds, a burn injury occurs. During the post-incident review, both parties are stunned. Neither realized the risk wasn't verified. No one took ownership. So the key takeaway is this: familiarity does not equal clearance. Patient history is not present-day safety. Every implant must be confirmed with up-to-date documentation and explicit communication. If something feels off, pause the study and ask. When the chain of MRI safety breaks, it's rarely due to the lack of tools. It's due to silence. So technologists often don't see the pressure of the radiologist, especially in high volume outpatient settings. They may be reading 100+ studies a day, covering multiple modalities while fielding stat requests, contrast approvals, and implant checks. Sometimes they're even off-site, which is basically a big case of today, where we see more of the radiologist off-site. That's why our communication must be clear, concise, and complete. Don't just say, oh, this looks weird. Instead, say, the patient has a VNS implant and the serial number doesn't match the chart. Can you please review this so I can proceed? The goal is precision under pressure. Radiologists make critical safety decisions based on our input. So being prepared and structured when communicating reduces the risks for everyone, especially for that patient. So let's talk culture. Culture isn't a written policy. It's what people do when no one's watching. A strong MRI safety culture isn't just about protocols, it's about behavioral norms that reinforce vigilance, accountability, and communication. In a culture of MRI safety, technologists are not allowed to speak up. They're expected to. Pausing the study, double checking an order, or questioning an implant is treated as best practice, not insubordination. Radiologists respond with support, not frustration, when concerns are escalated. This kind of culture is built through training, like safety refreshers and case reviews. Trust is where escalation is never punished. And empowerment, when radiologists make it clear they want to be contacted. So ask your teams, do MRI techs feel confident stopping a scan if something seems unsafe? Do radiologists thank us for flagging those risks? If the answer is no, the culture needs to change. Again, culture is not accidental. It's built by example, reinforced by leadership, and sustained by expectation. If you want safer outcomes, you need a safer culture, one where communication flows freely and safety is a shared responsibility. Again, I just feel a lot of this is my opinion. I've been in charge of a few departments, and this is how we had things set up, and things worked out phenomenal. But here's my conclusion. MRI safety isn't just about protocols, it's about people. It's built in moments of pause and questions asked and decisions made together. When MRI techs and radiologists communicate clearly, support one another, and share that accountability, patients are safer. Every scan is an opportunity to get it right. Let's commit not just to following the rules, but to leading with vigilance, collaboration, and a culture that never assumes silence means safety. I want to say thank you for everybody for listening to my lecture today. Sam, Julian, thank you for having me. I want to offer 25% discount for any one of my books. Please use the code EMRI 2025. And if you have any questions, you can always send me an email to magneticmindsacademy@gmail.com. So I want to say thank you very much. Have a great day.
Thank you so much, Doug, for sharing your insights. This is such a fascinating topic, and personally, I couldn't agree more, especially from a safety standpoint. I believe that assigning roles and understanding to whom certain responsibilities belong, I believe is essential. The outcome of an emergency response might differ depending on whether we as radiographer, as MR technologists, we have a very clear understanding of what are the expectations within our role. Now, you might forgive me if we try to move a bit faster this year, but we have quite a lot on our plate. We'll do our best to try to avoid to run over time, as history has taught us before. So the second lecture of the day is already about to kick in. Someone might argue that we at Everything MRI, we are a bit sentimental, and yet I have to say it is a pleasure to welcome back the second return to our stage. And I'm very delighted to have back here today with us Bill Faulkner. Bill is an independent consultant through the William Faulkner and Associates and has delivered MRI and CT education as well as MRI safety and clinical operation consulting for more than 25 years. His dedication to teaching spans even over a longer period, and as many of you know, he's the author and co-author of many MRI textbooks and papers, bringing also his own experience as an MRI safety officer. So Bill's return today, I would say, is very important for the overall event because it will help us to understand more about the basics of MRI and the basic of safety, meaning that it's going to help us to understand what causes certain type of injuries in MRI and which behaviors help prevention. So with a presentation titled Preventing Thermal Injuries in MRI, please join me in welcoming back Bill Faulkner.
Hello everyone, I'm Bill Faulkner. I'd like to talk to you today about preventing thermal injuries in MRI. Now, as we know, MRI systems use three very powerful magnetic fields, and each one has its own unique safety considerations. Today, we're going to focus on the time-varying magnetic fields, which include the time-varying gradient magnetic fields and the time-varying radio frequency fields. The time-varying gradient magnetic fields can induce current in conductors, and this could lead to some heating. Although the heating likelihood from gradients is less than it is from the radio frequency field. Nonetheless, the ACR points out in its 2024 manual that patients with implanted or retained wires in anatomically or functionally sensitive areas, and they give examples like the myocardium or implanted electrodes in the brain or next to or near the spinal cord, should be considered at higher risk. And there are some pulse sequences that utilize very high rapid gradient switching. For example, diffusion weighted imaging, typically if it uses echoplanar imaging, as well as certain cardiac sequences. So again, they can pose a risk, although the most likely source of thermal injuries is going to be from the time-varying radio frequency fields. Now, the three main areas that I want to focus on related to thermal injury are near field, or what are now called proximity burns. This is from contact with the bore wall. Resonant frequency, resonant circuitry burns due to conductive metals within the volume of the RF transmit coil. And then the formation of large caliber loops, which can result from skin-to-skin contact. Now, this is a RF distribution map from a body coil on a GE system, if I'm not mistaken. And it shows the percent of RF power relative to the position within the RF transmit coil. But very importantly, you should note that this map clearly shows that this graph relates to the RF field on axis, which is midline. And so at isocenter, which is this point on the graph, you have 100% of the maximum RF power. And as you move away from isocenter along the z-axis, you can see that it drops fairly quickly, getting down to 0 out towards the end of the coil. Now, to visualize this, I'm using one of the illustrations from Dr. Canal's Magnet Vision app, and I appreciate him providing this for me. You can see this is the midline, and this represents an unloaded body coil, but nonetheless you can see that along midline, maximum power is at the center, and then as it moves away from isocenter, then it drops off, just like you saw in the curve. However, the radio frequency field is three-dimensional. And I want to point out that the risk of a proximity burn is in the areas that come in contact with the bore wall. And this is where, if you look at the color map, where you have extremely high RF energies. And this would be areas such as the shoulder, the upper arm, the elbow, forearm, wrist, possibly even hand. So all of these areas of risk are actually outside your imaging field of view, and the area of risk can change with the landmark. This is why it's imperative that you provide padding between the patient and the bore wall of the magnet. Here's a video made for a client some time ago. It shows a technologist using the proper padding and positioning the patient within the magnet using this padding. She'll place the padding and then advance the patient in and ensure that there is padding between the patient's tissues and the bore wall. Again, you need to use a minimum of 1 centimeter of padding between the patient and the bore wall. Now, these proximity burns will almost always appear oval in shape at the areas that we mentioned. And additionally, they don't show up right away. Patient's not going to feel it. Patient may go through the scan, express no discomfort whatsoever, leave the facility, and then a couple of days, maybe even a week later, they show up at their physician's office with this full thickness burn. And these burns can be quite severe. They occur in the deep tissues, which is why the patient doesn't feel it, and this is why it takes several days or more for them to show up. Now, this example of a burn right here is not the worst burn I've ever seen due to bore wall contact. It would be this particular burn right here. This is full thickness burn, again, bore wall contact in a patient while they were under anesthesia. The burn is so significant, as you can see, that's the patient's ulna. This patient had osteomyelitis and has had obviously a lot of issues with this burn. These burns can be life-altering, and that's why it's so important to protect the patient from these bore wall contact burns, these proximity burns. This is from a user manual, and any MR vendor where there is a risk for this type of burn is going to tell you to put padding between the patient and the bore wall. If you'll notice here in this illustration, they're also showing padding between, for example, the patient's hands and the side of their body, also between their ankles, and that's to prevent these skin-to-skin contact burns. These occur when areas of skin-to-skin contact form a large conductive loop, and examples of where this can occur is a bare finger touching bare thigh, medial calves, as well as medial thighs. Another source of thermal injury is the use of equipment that has not been properly tested and labeled for use in MRI. Anything that's going to go into that room, and particularly if it's going to go into that room and it's going to be used on a patient, you need to provide that equipment. You don't want to accept outside of equipment because you don't know anything about it. And you can't take anybody's word for it. You have to be sure that what you're using is indeed properly tested and labeled. And this is an example of a 5-week-old female who received a significant burn due to the use of a hardwired pulse oximeter. In MRI, we want to use fiber optic pulse oximeters. And this burn was so significant, at the end of the procedure, you can see that it burned all the way through the tissues. And unfortunately, it resulted in the child having to have her arm, wrist, and hand, of course, amputated. You also want to be very careful when you have conductive material in the RF transmit coil, especially if it's elongated or closed loop. And again, anything you're going to put in there, you want to make sure that it's been properly tested and labeled for use in MRI. These items can become very effective antennas. So just because it's not ferromagnetic doesn't mean it's not a good conductor. And if you have a length of a conductor that matches a major harmonic, half wavelength, if you will, of your RF pulse or your RF field, then that electric field can produce current in that conductor, and the conductor becomes a very, very efficient antenna, and it can heat tremendously, and it can heat very rapidly. Additionally, the risk of heating can vary with the length of the conductor at different field strengths. In this example, courtesy of Dr. Frank 𝐂𝐿𝐼, you'll notice this MRI pacing lead heating experiment with no implanted pulse generator. So when this lead, and this is essentially an abandoned pacing lead, when this lead was scanned at 3 Tesla, you'll notice there's absolutely no heating whatsoever, and that's because of the different frequency, or the specific frequency and therefore wavelength. However, at 1.5 Tesla, because you're dealing with a lower frequency and therefore longer wavelength, the lead heated tremendously. Furthermore, I want to point out that at 3 Tesla, it was scanned at 3 watts per kilogram, while at 1.5, it was scanned at 1.4 watts per kilogram, illustrating that you can still get significant heating even if you are in a lower SAR mode. Another source of patient injury can be the use of an improper transmit coil. Now, in this illustration, again, courtesy of Dr. Frank 𝐂𝐿𝐼, you see 2 examples. This is showing a deep brain stimulator. And if you scan with a transmit and receive head coil, then only the head is receiving direct RF radiation. If you scan, however, with the integrated body coil as the transmit coil and the head coil as the receiving coil, then the pulse generator is going to get direct RF radiation. And this can result in significant injuries. Understand that the configuration of your head coil can vary depending on the system vendor. And they can look very similar. This is a Siemens transmit and receive head coil, and this is a Philips receive only coil. And again, they can look similar. So you want to make sure that you're using the proper coil. Here's an example of actually a lot of conditions of use being not followed. This is a patient with bilateral deep brain stimulators. One of the pulse generators, however, was implanted in the abdomen. The gentleman was a duck hunter, and he wanted to be sure that he could still, get a shotgun up in his shoulder. And so they implanted the pulse generator lower on one side, which means it's going to have a longer lead. The conditions of use for this particular deep brain stimulator were 1.5 Tesla only, transmit and receive head coil only, with a head SAR of 0.1 watts per kilogram. Unfortunately, the patient went to a facility where they elected to scan his lumbar spine on a 1 Tesla magnet. So incorrect field strength, incorrect transmit coil, and incorrect SAR settings. During the exam, the patient began to exhibit neurologic symptoms, and when they were able to follow him up under the conditions of use, they found that there was this large lesion in his thalamus. Essentially, the lead tip heated and ablated that tissue in his brain. A very important practice as it relates to preventing thermal injuries is, in fact, changing all patients out of street clothes. No street clothes should be allowed whatsoever. Patients should remove all removable items, and they should be dressed in MR appropriate attire that's provided by the imaging facility. Here's an example of an 11-year-old girl who had presented for an outpatient imaging of the spine. She was wearing you can see a gray undershirt under a long sleeve white t-shirt, gray sweatpants. She was sedated, and when she awoke, she complained of pain along her flank. And as you can see, there is second-degree blistering along her flank. The ACR in the 2024 manual reminds us that clothing, increasingly we're seeing clothing with metallic and conductive materials. It's not reliably disclosed in the package labeling. In fact, in the U.S., the Federal Trade Commission allows manufacturers up to 5% leeway with what's actually in the labeling. So the ACR says that for anatomic regions with or within or near the volume of the RF transmit, that to avoid these concerns, they recommend gowning the patients to skin. That means removing underwear and wearing only MR pocketless garments supplied by the imaging facility. And my favorite would be scrub pants, pocketless if possible, and a hospital gown. I would also recommend removing socks, replacing them with the no-slip stockings, socks that are kind of readily available in most hospitals. And not dealing with thermal injuries, but again, another reason to change patients out of street clothes is so they don't bring stuff in their pockets. This is from several years ago, where a gentleman walked in with street clothes and he had a pocket knife. It flew out, opened up, and hit him in the eye. It resulted in a fractured orbit. I'm aware of a situation here in the States not too long ago with similar things, except he ended up cutting his arm. So remove all street clothes. Also, remove all removable items. But if you can't remove them, then you should discuss the situation with your MR safety officer or your MR medical director or the radiologist supervising the exam. Most of these body modifications and piercings, you can, number one, determine if they're ferromagnetic by using a handheld magnet or possibly even ferromagnetic detection. And most of them are in reality too small to heat. If it's less than 2 or 3 centimeters, it's really too small to heat. But you should evaluate these on a case-by-case basis. And then lastly, I'd like to remind you of the full stop final check as recommended by the ACR. I like to think of this like a pilot's checklist. Pilots, before they fly, every flight, they go through the exact same checklist, double checking, make sure everything is functional and there are no safety issues, again, before every flight. The ACR describes 2 types. They describe a routine, something that would be used in a typical ambulatory setting, and then also an augmented full stop final check. These are for the more complicated cases. So for example, routine would include visual inspection, double checking the patient's identity, making sure all the screening forms have been properly filled out and all the questions properly answered. It's always a good idea to ask the patient multiple times, is there anything in you or on you that you weren't born with? Double check anything that's going to go into the room. Make sure if the patient has any type of implants or devices that they've been thoroughly vetted. If you have any kind of on-planet device that needs to be removed, glucose monitoring devices, for example, make sure this has all been taken care of. Then with the augmented final check, it really is essentially the same thing, but you're going to also need to check and make sure that any accompanying personnel have been properly screened. Any items that is going to go in with the patient, make sure that they've been properly checked. Again, double checking the patient, particularly if they're unresponsive or heavily sedated. just double check, and make sure that anything that's going into that room with that patient and anybody going into that room with that patient has been properly MR safety screened. So that brings me to the end of this presentation. I want to thank you for your time and attention. It's a privilege to have the opportunity to speak with you. So until next time, thank you and take care.
Thank you so much, Bill. I do really feel that this insight on this critical topic will be beneficial not only to those radiographers that are moving the very first steps in the MR modality, but also those a little bit more experienced. Ultimately, an injury like those you have described, they often occur when we kind of like lower our guard, probably when we become a little bit too confident. So thank you for reminding us what are the causes of these injuries, but also especially what are the behaviors that help us to prevent them. So okay, now time to move to the third presenter of the day. This time is a completely new face, someone I literally pushed to have this year, not only for the great impact she's having on our community of radiographers, but also for the great professional she is. So I'm very glad to have here 𝐂𝐻𝐿𝐴 with us. 𝐂𝐻𝐿𝐴 is the MRI strategic lead at the Royal Marsden Trust in the United Kingdom, playing a key role as a valuable member of several UK bodies focused on MRI and medical imaging. In one of our latest Everything MRI podcast episodes, which will be released in just the next few months, 𝐂𝐻𝐿𝐴 has revealed that as part of the many tasks she has to cover as an MRI strategic lead, one of them is actually ensuring appropriate safety training and also teaching her team on how to deal with emergencies. And we're talking about a team of over 100 MR radiographers. So through her experience, I have to say she has encountered a wide range of different skill sets, different learning styles. At the same time, she always prioritizes MR safety training as paramount. So I hope you are as excited as I am at the moment to have 𝐂𝐻𝐿𝐴 here. And I would say let's give us a very warm welcome, since she's like our very new addition. And she's going to deliver a presentation which will be completely focused about incident training in MRI. So 𝐂𝐻𝐿𝐴, when you're ready, the stage is all yours.
Hello, and thank you to Samuel and Julian at Everything MRI for this kind invitation. My name is 𝐂𝐻𝐿𝐴, and I am the lead MRI radiographer at the Royal Marsden Hospital, and I'd like to share our experience with you of incident training in MRI. So why do we need incident training? Well, MRI is a very high-risk environment. The majority of MRI systems in the UK and around the world tend to be high field strength, 1.5 Tesla systems and above. They're superconducting magnets that have very strong magnetic fields, and there's a potential for serious injury and even death if the access to these machines is not strictly controlled, as well as a heavy financial cost if things go wrong, either through damage to the machine or litigation through injury or fatality. So over the years, MRI has become much more accessible, and it's only right that this fantastic technology is more available. Historically, MRI scanners were few in number and generally installed in basements or at the end of dark corridors, hidden away, a little bit special, but now they are everywhere, quite rightly, just another machine in many busy radiology departments and clinics, and with that comes the pressure on services to scan more and more patients as efficiently as possible. Technological advances such as AI-enabled acceleration software allow us to scan more patients with the concern that there will be a proportionate increase in MR-related incidents. Remote scanning also offers new and more efficient ways of working, therefore it's essential to have robust training, safe working practices to mitigate any risks. Here are the 5 sources of risk from the MRI environment. The most reported incidents happen as a result of the static and radiofrequency fields. But for our incident training, we are primarily concerned with static field effects and cryogens. To support us in providing a safe working environment that protects everyone, staff and patients alike, we of course have regulatory frameworks that our own local rules are based on. This includes written emergency procedures and policies of how to deal with all safety scenarios, including managing implanted devices. Currently, it's a 50-page document with associated emergency procedures and implant policies, all very essential and have to be evidenced as being read. But training competencies and practical incident training help to embed policy into practice. It's essential that this high-risk environment is safeguarded by MR safety trained personnel and that there are clearly defined roles within the organisation. Access to the controlled area is via security swipe and it's granted only once the required level of training is achieved. We use terminology common to the MHRA guidelines and e-learning for health that align to our own levels of access in MRI. These are the emergency procedures we need to be prepared for: projectile, quench, fire, and patient-related clinical emergencies. In MRI, we all know the risks posed by the static magnetic field of a superconducting magnet, but externally there's a common perception that it can be switched off, or that if we're not scanning, that the magnet isn't on. MR-Linacs and PET-MRs are still very powerful MRI scanners and need to be given the same safety requirements. We have a joint safety committee at the Royal Marsden with radiotherapy so that we can share practice and write policy jointly, so we have a common approach to safety, which is really important. MRI safety awareness is improving, but requires constant messaging. International MRI Safety Week was launched in 2019 in memory of an 8-year-old boy who died in an MRI projectile incident. Michael Colombini would have been 24 years old now. And this accident happened in the very same year that MRI Safety Week was launched, and is a reminder that when you're taking tools into an MRI environment or any kind of equipment, that it needs to be safety screened, it needs to be assessed and authorized by an authorized person, and that you have appropriate labeling on all of your equipment within the department. And this is really fantastic for to be audited as well regularly. I've included this projectile incident in 2023 as the non-MRI staff member who took the bed into the magnet room had undertaken MRI safety training e-learning, but that they were not authorised to enter the magnet room and should have been supervised. It just demonstrates that e-learning is a useful tool to extend the reach of safety awareness, but it's no substitute for more intensive MRI training and experience. When accidents do occur, they can be very expensive. £700,000 or near enough, because the trolley ended up down a bore. Thankfully, no one was hurt, but the patient was trapped for a considerable time and it was a considerable expense. And these sorts of things aren't covered in your maintenance contract at all. I have included this slide of a very recent fatality in the USA to show the importance of following procedure, and that anyone within the controlled access area should be safety screened and demetalled if there is any possibility that they may enter the magnet room, or unless they are under constant supervision. The projectile risk can be mitigated by making sure that only authorized personnel have access to your controlled access area. You need to be constantly vigilant and make sure that you're aware of who is in your department and what levels of training and access they have. Supervision of the magnet doors at all times is essential, and making sure that if your magnet doors are not in use, then they should be locked. Supervision of non-authorized persons and visitors is constant, but if you have authorized personnel, for instance, during an anesthetic list or during a nurse-led sedation list, if these people are not always in MRI, then it's worth having the next level of supervision for these people. They may well have training, but it's important for them not to gain access to the magnet room or take things in without checking. Maintain your physical barriers. If you have tensor barriers, if you have secondary doors, make sure that they're working and that you use them at all times. And then know what to do if there is a projectile incident. We work through these in scenarios within our incident training, which we'll come on to. Another good point of practice is consistency of labeling of our equipment, and this is constant between our departments as well. And it's just useful to make sure that we label our switches clearly so that it's very clear, you know, which button is our quench button, which button is our electrical stop button, and that we have consistent labeling of equipment so that all the staff, this becomes ingrained. And so when we do incident training and scenario training, they know which button to press for what. It just makes it all clearer. A quench may happen either spontaneously or via control rundown in an emergency. It's important to know when to quench and when not to quench. And basically the rule we have is if there is danger to life or limb, then it's appropriate to press the quench button. Our staff are trained during incident training to give them freedom to act to do this. It's a substantial amount of gas that would be released as a result, and so invariably there is a danger of asphyxiation in the event of a quench, and it's important to know how to deal with this in terms of keeping low in the room, acting quickly and making sure that you remove your patient as quickly as possible, securing the magnet door and obviously reporting this. Fire training is mandatory in the trust, but when it comes to MRI, it's important to have clear written procedures specifically for how to control access in the event of a fire and advice to the fire team. We have fire wardens and we have instructions at switchboard and for the emergency teams to know how to deal with the magnets in the event of fire. As part of our incident training, we will practice clinical emergencies. Only MR authorized personnel can evacuate a patient from the scanner into the preparation or recovery area. All patient support must take place in the preparation area, not inside the scanner. We raise the alarm within the unit and we call the crash team. The crash trolley is immediately available and we secure the magnet room door. So these are the scenarios that we practice and we do this quarterly. Can you imagine either the fire service or first responders coming into an emergency situation having never done any practical training? And this is where our incident training stems from. We want to make sure that our staff have the confidence and the experience to respond to emergencies, whether it be a fire, a quench, or a patient emergency, to be able to get the patient out quickly and be able to respond in a way that keeps everybody safe. This is how we do it. So in terms of training, everybody will have e-learning. So everybody that has takes part in incident training will have an awareness via e-learning, and our e-learning also is done at the appropriate level. The workplace, we have workplace learning and competencies for all staff, and then our practical instruction and drill training is done quarterly. I would require all radiographers and RDAs, in fact, and physicists, anyone working on scanners, either scanning volunteers or patients, they all have to have done at least one practical drill training per year. They can do as many as they want to be confident, but we require everyone to at least have done one practical session per annum. We always ask for reflection and review and feedback because the important thing is to make sure that we're being effective with our training and that we're covering any gaps. And the staff groups that this applies to are obviously our MRI staff, both core staff and anyone that rotates through MRI, radiographers, RDAs, radiologists, physicists, our nurse-led sedation service and our receptionists. We have an incident team, we have an intensive care team, anaesthetics, and a nurse-led sedation team. Many of these people are very experienced now in working in the MRI environment, but as experienced as they are, they're still at a certain level where they still require us to give them access to the magnet rooms because they don't work in the environment all the time. We undertake the training quarterly, and this tries to capture staff that are on shift, changing staff, people coming and going all the time in all sorts of disciplines. It's not perfect, but we try to make sure that we capture people as quickly as possible. But we require everybody that by the time they're signed off with their MR safety training, they have to have done at least one emergency evacuation of a patient. We schedule this time on the scanner, so the scanners are booked out, usually for 2 hours. and we ensure as many staff are available as possible. So we liaise with our modality leads to try and free people up so they can come along in a staggered group and relieve each other so that we can capture as many people as possible. And then we keep records to keep track because we want to make sure that everybody is compliant and confident, and to safeguard themselves, but also to support them and to make sure that we are doing everything we can to protect our patients. We do an annual review to ensure that all clinical authorised personnel do at least one drill session a year. And I really do like feedback about this just to see how effective it is. And we take on board the comments that staff have, how they feel about, evacuating a patient on a table that's detachable rather than using a trolley. Some staff prefer to use trolleys. Some people don't like to detach the tables, especially since some of our tables then refuse to go back on the scanner. They can be a bit temperamental, but we make sure that there's available emergency equipment at all times, and people can do whichever method they feel comfortable with and confident with, as long as they are aware that they have to get the patient out as quickly as possible and secure the magnet door. And what does the training include? Well, we have a walkthrough of our safety features in the department, and this is supported by our clinical scientists. I appreciate that not everyone has clinical scientists and physicists in their departments, but just some very simple measures like having appropriate labeling on your emergency buttons to differentiate between them. Sometimes quench buttons and electrical stop buttons can look very similar, for instance, so it's important to have consistent and clear labeling. So, looking at all those safety scanner features on the scanner fascias, on the tables, revising all of those because we don't use them every day, and so it's important to, to make sure that the emergency, where they are, and what they do and how to activate them. Simulation of a patient emergency drill and removal from the machine. So we do this in two different ways. We can either detach our table or we can take a trolley in and pat slide a patient across. And what we do, we walk through the scenarios using patient emergencies like arrest, a panic attack, a fit. And what we try to do is look at the worst case scenario and try and carry out the scenario when there would be a minimal staff available, because unfortunately when these things do happen, they tend to happen either out of hours or they can happen over lunchtime when you have not as many staff available to help transfer or to raise the alarm. So that's the worst case scenario really. And we try to emulate that when we do our scenario, and everybody else watches and tries to see what else we could do differently. We time it, and we make it fun, but there's a serious side to this in that we need to time how long it takes to get our patient out and to be as effective as possible. It's good to have a measure of the effectiveness of practical incident training. And we have previously issued questionnaires prior to training and afterwards. Questions mainly are based around knowledge, where are your emergency buttons, which button do you press for what, when would you quench, when wouldn't you quench, how would you deal with an incident, and and various scenarios, and looking at confidence scores, how confident are you to deal with an incident prior to training, how confident do you feel after the training has been given. And generally the feedback is very positive. Staff feel more confident by having practical training and not just relying on what they've read. We also like to gather information about a specific role. We have a multidisciplinary team of radiographers, RDAs, physicists, admin, nurses, and it's important to make sure that we're meeting the needs of all the different roles and responsibilities. And we're meeting expectations. We always look at suggestions, any suggestions the staff have of making their emergency response safer and giving them the confidence and freedom to act as and when they need to. They prefer frequent updates and they also like snacks. So what we try to do is provide some form of confectionery on the day. So our theoretical training and standard operating procedures and local rules, they go some way towards educating and informing staff. However, there is no substitute for the practical elements of drill training. Just as we do in the fire service and emergency response, what we want to be able to do is reenact those scenarios so that staff have the confidence to undertake emergency evacuation, to know what to do in all those emergency situations. And then this also guards against complacency, because just because something hasn't happened doesn't mean it can't. So it's important to keep staff on alert to be able to react in the right way at the right time. We appreciate review and feedback from our staff groups, and we'll always try and facilitate anything that they need to make them feel safer. And in the future, it would be fantastic to be able to use technology, perhaps via virtual reality and new technologies to enhance our learning, because I appreciate not everybody can allow magnet time to be able to practice emergency drill training. I appreciate that. I would advocate it, but I appreciate sometimes why it's not possible. And in this new technological era of AI advances, we've seen some fantastic time savings with deep learning algorithms that have been applied to imaging. There are all sorts of fantastic things. There's never been a better time to be in imaging, but the technological advances, instead of all of this resource being put into time saving regarding scanning more patients, it would be nice to be able to put some of this time aside for incident training and use this as part of our risk management strategy. It's so important for staff to have the time to be able to practice this important work, and also making sure that they are kept happy with their snacks. I think of the future as being like a sandwich, with radiographers being sandwiched in between technology at the top and healthcare priorities or efficiencies, workforce transformation underneath, with us being the filling in the middle. And I think instead of being squeezed, we need to strive to be the best clinical experts, advocating for our patients, personalizing care and using technology to our advantage. Being leaders in MRI safety through experience and training is a huge part of our role and should be valued. I've included some resources here. There's so much that is freely available and some really exciting content. We all learn in different ways, and there are lots of different ways to access MRI safety training. Here are some useful references. And many thanks indeed to Everything MRI for this learning opportunity and for the innovative way in which they are teaching and spreading the word on MRI. Thank you.
Amazing, Erica. Thank you so much for sharing this. It is incredibly valuable knowledge for our community. I think we all know how important it is to react effectively when things go wrong, and things can go very wrong, as history has shown us, including some of those recent events that many of us have definitely heard about. I think having this type of information at our fingertips is crucial for changing mindsets and reminding everybody the importance of training. Okay, so the next in line is another familiar face, probably not just for this event, but I would say for the wider community. And I'm very pleased to welcome back Tobias Gill to our panel. Tobias has been involved in MRI safety for more than 20 years, beginning his career designing MRI facilities before broadening his focus to include all aspects of MRI safety. He has served twice on the American College of Radiology MRI Safety Committee. He's a founding board member of the American Board of Magnetic Resonance Safety, and he holds ABMRS credential as both a MRSO and MRSC. So with today's presentation, Tobias will cover some additional layers about MRI safety, particularly focusing on structures and education. So ladies and gentlemen, let's enjoy everyone Tobias' lecture.
Hi there. Welcome to Not Fit for Task, MRI Safety Structures and Education. I will be your presenter, Tobias 𝐂𝐐𝐏𝐿𝐿, Certified MR Safety Officer, Certified MR Safety Expert, founder of 𝐂𝐐𝐏𝐿𝐿 Radiology Consultants, principal with Radiology Planning, founding board member of the ABMRS and one of its past chairs, and a two-time past member of the ACR's MRI Safety Committee. My disclosures, which I don't think are going to have anything to do with today's content. I am an employee of Radiology Planning. I'm the founder of 𝐂𝐐𝐏𝐿𝐿 Radiology Consultants, and through GRC, 𝐂𝐿𝐿 Radiology Consultants, I have an ongoing consulting arrangement with Cook Medical. Again, none of these I think are going to be germane to today's talk. Also, whenever I give a speech presentation on MRI safety, because I'm a member of the ABMRS and I sit on some of the exam specification committees, I just want to make it clear that while I see the examination questions, this lecture is not going to include questions or answers to the certification exams. So, we don't have a whole lot of time together today, so we're going to just sort of touch on three areas. Radiation safety's red-headed stepchild, in other words, kind of unwelcome companion, structures for MRI safety and MRI safety training, where we stand. Let's start with radiation safety's red-headed stepchild. So, we've done a bad job. We, healthcare, have done a bad job making sure that MRI safety is addressed. Oftentimes, when it does get addressed, it gets sort of tucked in under radiation safety. Now, radiation safety is not exactly sure what to do with us, because in many parts of the world, when we talk about radiation safety, that means either explicitly or implicitly ionizing radiation safety. And so those folks with a perspective towards ionizing radiation, they look at MRI, and MRI markets itself as the safe imaging option, and they're like, well, what the hell are you doing here? Right? You don't belong here. You don't represent a comparable risk. I want to challenge the notion that we don't represent, that MRI safety, MRI risks are not on the same plane as ionizing radiation. I think that they're not, but not in the way that often gets described. So let's just start talking about risk, shall we? So this table, this is one that I took from the internet, and it essentially, it's a 2D graph. 2D matrix. And on the vertical axis, we have the likelihood of the bad thing happening. And on the horizontal axis, we have the consequence or cost of the bad thing happening, right? So from likelihood, if you go up from the bottom of the matrix, we start from rare and we go all the way up to almost certain in terms of the likelihood of the bad outcome, right? And then on consequence, we go from the left-hand side, insignificant, to the far right-hand side, critical. If we look at ionizing radiation in the diagnostic setting, I realize we have radiation therapy and we have intervention where we have higher levels of exposure. For the moment, we're just going to talk diagnostics, right? We don't really have the radiographers, or even really the radiologists or the department managing the concrete risks of ionizing radiation safety because they're incredibly small. I mean, yes, we have structures in place that if a patient receives inappropriate exam or the wrong dose or something like that, yes, we log that. But for the most part, if we look at ionizing radiation safety, the risks that receive the greatest attention are the stochastic risks, the risks that we have no idea if you, in your chest CT, If you're going to develop cancer 10 years, 20 years, 30 years down the line, we know that some proportion of people, or our best guess is some small proportion of people who get that chest CT will develop cancer. We have no idea of how we figure out whether that's going to be you or somebody else, the next person, or somebody 1,000 people after you. We just don't know. We understand that that risk exists, but we don't have any clue on how to manage it on a case-by-case, patient-by-patient basis. How do we manage those risks? Oh, well, we make machines that expose the patient to lower doses, right? We have better criteria for when the benefit outweighs the risk in terms of referring patients for that chest CT study. All of those things are really pretty much out of the radiographer's hands. They are policies and practices and engineering of the CT device, those types of things. So when we look at what of these things, what of the actions of a radiographer can meaningfully reshape the risks, the stochastic risks, there aren't any. It's an unsolvable problem from the perspective of, hi, my name is Mr. Jones, I'm here for my CT scan, right? In that moment, what control does the radiographer have over that risk? Functionally none, right? So we recognize that in terms of using this grid with the criteria or the categories as they're presented, the risk of those stochastic negative outcomes is rare, very rare, in ionizing radiation, right? What are the costs? What are the implications or the consequences? Well, if a bad thing happens from those stochastic risks, it could be very minor, but it could be catastrophic, right? It could be critical on this diagram here. But it's almost certainly in that bottom row of issues. What about MRI? Now, in MRI, we don't have stochastic risks that we're aware of, right? We have immediate concrete risks. We can burn somebody. We can interfere with an implant or medical device. We can cause auditory damage, right? We can have objects flying across the room and hitting people. These are all pretty concrete implications. Do they approach the almost certain frequency or likelihood? No, they are rare. Similar to the rarity of ionizing radiation negative outcomes, they are very rare. We can have discussions or debates about, this number is smaller than that number, but they're both very, very small numbers, right? The frequency, the likelihood, given the number of studies that are done, that a negative outcome will result, right? So they're both in the rare category. And again, from the consequence standpoint, there are things that are insignificant, and there are things that would be viewed, in my opinion, as critical from the MRI side of things. So this graph would seem to suggest that if we're handling the risks of ionizing radiation and MRI, they should fall into the same strata, the same general criteria, and we should address them with similar levels of seriousness, right? However, there's one thing that we don't often talk about that I think warrants at least a quick introduction here, and that's, when does the negative consequence occur? Again, for MRI, we said it happens right now, but the stochastic risks from ionizing radiation exposure happen 5 years, 10 years, 20 years, 30 years down the road, depending on the nature of the developed cancer, right? So what if we took this 2D graph and we added a third dimension, right? When does the check come due? When do we have to pay the negative consequences? And if everything is all about quality of life and lengthening the high quality of life, then I would argue that if we're looking at the stochastic risks of a CT study versus the concrete risks of MRI, we should be looking at a 3D version of this graph. And I've added a how soon z-axis to this particular graph. And now the stratification or the color coding of the original 2D graph was as I found it. I've taken the liberty of sort of applying some different colorization, stratification of the risks or the severities or the importance of this based on the time frame for this. So if we take that original graph and we assume that all of those costs or consequences are immediate, right now, and then we add 2 more strata, and we could add 5, however many you want, from weeks and months from now to years and years from now, or sort of immediate weeks or months, many years is sort of the 3 tiers of timeliness. If I'm going to develop a solid tumor, but that tumor is not going to manifest itself or be diagnosable for 20 years, 30 years, or whatever, and I essentially get that much quality of life before there's a problem, before there's a health consequence that needs to be addressed, or that negatively affects my life, then just the fact that it's delayed means that the impact on total quality of life over the expected span of my life is reduced, right? So in some contexts, I think it's arguable that we need to be looking at MRI risks with at least as intense and perhaps more intense preventative mindset than we do to ionizing radiation. The stochastic risks are unmanageable. They are unsolvable problems for the radiographer in the moment that the patient shows up, for the most part. Whereas on the MRI side, the burns, the projectiles, the hearing damage, the implant and device interference, these are overwhelmingly manageable, preventable harms based on the knowledge, the skill, the competency of the radiographer and the structures in place to help reinforce industry best practices. So let's move from risk to the structures for safety. So I'm going to introduce you to just a few representative samples of standards, accreditation standards from different parts of the world. We're going to start with Joint Commission International. And what we're looking at on the screen right now is the sum total of JCI, Joint Commission International's radiology or imaging standards. They don't mention MRI. So they certainly aren't prescriptive about MRI safety best practices. This is it. This is safety standards for hospitals around the globe, right? Joint Commission International. Now, there are other accreditation organizations. This is 𝐂𝐈. 𝐂𝐈 is a healthcare accreditation organization based in the Middle East, Saudi Arabia. And again, we are looking at the sum total of standards for radiology from 𝐂𝐈. And again, they don't really mention MRI, and they certainly don't prescribe any MRI safety practices. Now, I don't mean to pick on accreditation organizations in parts of the world other than where I live, right? So this is an excerpt from Joint Commission, the Joint Commission, TJC. TJC, or Joint Commission, accredits hospitals in the United States and Canada, and their US and Canada standards are vastly different from the Joint Commission International, JCI. They actually do have MRI specific standards. They're weird. They don't really speak directly to the direct causes of MRI accidents and injuries. So It's better than not having anything, but they're not great. Here's just a couple of examples. They prescribe that the facilities must manage the risks, but they don't actually give them any tools for what standards or what practices would effectively manage these risks. So when there aren't effective structures, thou shalt have MRI safety training on an annualized basis. Thou shalt make sure that the content of that safety training includes X, Y, and Z. Thou shalt have minimum competency trainings in the following areas. Thou shalt regulate access controls in and out. When standards don't exist, we have to rely on you. We have to rely on the knowledge of the radiographer, the individuals at the point of care. How do we convey MRI safety training information? Well, historically, it's been word of mouth, hand-me-down information. My senior radiographer taught me X, and they knew that because their senior radiographer, when they were junior, taught them X. And that person knew what they knew because you begin to see that we essentially pass down information without necessarily referencing it to some sort of standard body of knowledge that we need to have. Now, this kind of peer-to-peer hand-me-down information or hand-me-down knowledge transfer works great for things that don't change all that much. Human anatomy. This is actually sort of part of the way that we teach human anatomy and physiology and pathology is we do this, sort of peer to trainee. Human anatomy doesn't change all that much. MRI safety has changed worlds in the last 20 years. And if the mechanism that we're relying on is hand-me-down information without cross-referencing this to standards of contemporary practice, we're missing out. So today there are some newer structures that are beginning to manifest related to MRI safety training of technologists and radiographers. The problem is that not that those new structures are poor, it's that if we're only focusing on training the new crop, then all of the senior radiographers, technologists, radiologists are still working sometimes from a position of ignorance. Now, I mentioned radiologists. Let's just for a second, let's talk about radiologists. And we'll talk about them from my country, the United States. In the United States, the organization ACGME, which I think is American Council of Graduate Medical Education, ACGME sets the minimum training requirements for residency programs for all the clinical specialties, including radiology. In 2025, the minimum residency training requirements for the ACGME require 0 MRI safety training. Now, there are residency programs that do a great job training their residents. My point is that the standard for the industry is, whatever you get is good enough. And I think that that's woefully inadequate for providing top-level quality of care. Now, I said that's radiologists. What about hospitals? Hospitals don't often have really good policies, procedures, or structures for managing MRI safety. Oftentimes they sort of shrug their shoulders and say, well, we don't know anything about MRI safety. The radiographer, the techs will handle this for us. And as a result, there are all of these practices that really have no institutional backup. And the hospitals and the institutions really haven't taken their part in the responsibility. One example of this, Dr. Elizabeth Potter is a breast reconstructive surgeon in Texas in the United States. And she had a patient who they were planning on doing reconstructive surgery on this patient. And the patient had gotten, well, I'll let her tell the story here.
Hey guys, it's Dr. Potter. It's Friday. I'm just leaving the hospital. I saw 65 patients in the last 2 days in clinic and operated on a sweet lady just now. I just want to share the story with you and you can draw your own conclusions. But she has breast cancer, had tissue expanders placed at this hospital recently, and then was at home recovering and had a seizure, came to the ER, and they did a brain MRI. And we realized when we saw the report, a note like saying, hey, your patient's at the hospital. And we looked and it said she'd had an MRI. And I was like, that's impossible. She has tissue expanders. You can't do an MRI when you have tissue expanders, or you shouldn't. And we checked and they actually had done that. So unfortunately, she's going to need more brain MRIs. And so I talked with her oncologist and I just took out her expanders so that she can have that done safely. But the expanders were torn. Looked like from pressure from the MRI. And when I asked the patient ahead of time before surgery today, she said, I was trying to tell them I had expanders in. And she's like, it kind of hurt when I had the MRI. So I know that someone would do a root cause analysis and say that it was nobody's fault. But this lady with breast cancer came in with seizures. And somehow, even though she has tissue expanders, if you look at her chest wall, if you read her chart from 2 weeks ago, she has tissue expanders. Maybe they thought it was safe. Maybe they didn't know. But it happened. And I'm glad that she wasn't harmed more by that. But yeah, like the system is so big and I just feel like everybody's always saying it's not really anyone's fault. It's the system's fault, I guess. We took care of her today though.
It's not just the system's fault. It's the fact that we don't have systems for MRI safety. And therefore, everything kind of flows down to the radiographers to manage on behalf of the radiologists, on behalf of the hospitals and healthcare systems. Now, in the United States, and I'm speaking about that because that's what I know the most about, in the US, we don't have MRI safety specific formal training requirements. And it's my opinion that we are seeing growth in anticipatable, preventable injuries because we aren't implementing minimum safety training requirements for our radiographers, for our radiologists, for institutions, for management. We're not implementing safety practices minimum expected standards. Now, I don't mean to be all doom and gloom. This is not all bad news. There are changes that are afoot. I'm going to share some information about that in a second with some QR codes if you want to get your phones out to download some documents. You are the beginnings of change. You are here. You are actively participating in this. And through you, we can begin to elevate standards of MRI safety. So, takeaways. From a safety standpoint, we've been backsliding, or at the very least not keeping up with the increases in risk. And that's been happening for decades. It's a long problem. We're not going to solve it overnight. I think that recent accidents are illustrations of sort of cracks in the foundation here. Now, we can make changes. There are changes underway, but if we put all of our faith in changes in radiographer training programs, right? It's going to take 15, 20 years for those radiographers coming out of those programs today to be in senior roles to where they might be able to reshape things. We need existing radiographers, existing radiologists, existing healthcare radiology administrators to take on their part. Now, I talked about one of the problem children, ACGME. If you're interested in seeing what is required of radiologists for their residency in the United States, you can visit this site and download their program requirements. A couple of resources or bright lights here. ASRT, the American Society of Radiologic Technologists, they actually have a new curriculum for technologist aides. Here's the thing. Their MR technologist aide curriculum requires the teaching of all kinds of things that I think should be standard for all MR radiographers, technologists. And also, I'd love to share with you our new book, the Technologist's MRI Safety Handbook, now available. If any of these resources are useful to you and help you deliver safer and more effective care for your patients, I will be absolutely overjoyed. I want to thank you for joining us for Not Fit for Task, MRI Safety Structures and Education. And thank you to Everything MRI for this opportunity to be here with you.
Beautiful, Tobias. Lovely lecture. I have to say, last year I had plenty of questions for you, and trust me, nothing has changed. It will not be any different this year. I'm sorry you cannot escape. In the meantime, thanks again for being one of those that believed in Everything MRI since the very first day. Okay, we have another 2 speakers before meeting each one of them at the round table. The next one is another new face within the Everything MRI Safety Forum, and he's an expert that definitely adds value to this event. I'm very glad to have with us Professor Vitor Silva. Vitor is a senior radiographer with a PhD in occupational safety and health. He regularly works as a radiographer supervisor in Portugal, but he has distinguished himself as an expert academic as well, contributing to MRI research groups at both national and international levels. He also produced quite a lot of valuable papers and lectures, especially in the field of MR safety. And I have to say, I've attended one of those myself. And I must say, it's very difficult not to get engaged with Vitor's passion about this field. So today's presentation is one of those that MRI nerds like me personally really like a lot. We often argue in the Everything MRI YouTube channel that even safety, especially safety, is tightly linked with other aspects of the MR workflow, and one of them is definitely the image quality. So Vitor today is going to try to address this specific intersection between different aspects of MRI. So from the title, Smart MRI, Optimizing Safety, Preserving Image Quality, when you're ready, Vitor, feel free to take the lead.
Good evening. First of all, thank you for the opportunity to Everything MRI, namely to Sam and Julian for being part of the speakers of the MRI Safety Forum 2025. It is a privilege for me to be here with you. This is the outline of my presentation. I will start to make a brief introduction about the theme, and I will go forward to some safety decisions in optimization regarding MRI safety, such as radio frequency and patient heating, gradient performance in some sequences that will cause the PNS risk, the acoustic noise exposure, and sequence optimization. And I will talk about some parameters that influence directly some parameters about image quality in MRI. Finally, I will show to you 4 clinical scenarios and practical one, and make some conclusions and take-home messages. In MRI, regarding image quality, we are looking always for the perfect compromise between signal-to-noise ratio, speed of acquisition, and image resolution. And many times, when we change in some parameters, we will change these 3 main pillars, and sometimes in a negative way. So when changing, we have always to think that in MRI there are compromises regarding image quality that have always taken into account the contrast-to-noise ratio, the absence of artifacts, and MRI safety. We all know that MRI works with 3 different electromagnetic fields: the static magnetic field, the magnetic gradient field, and the radio frequency fields. They all play together, but they have well-defined risks and effects that are independent from each other, from each electromagnetic field that is used in MRI. And on the other hand, we have more and more patients with implants, active or passive ones. This is one example of a neurostimulator that when we perform an MRI to a patient with this active implant, we have to respect many conditions to perform the MRI in a safely mode. And some of those conditions are the levels of SAR, the limits of the scan time, and many others. And the limitation of the scan time can be a problem because sometimes we have very long examinations. And in this case, the patient must perform the examination in 30 minutes of scan in a period of 90 minutes. So the radiographer sometimes has to change some parameters to respect that condition, but those changes must maintain the image quality in terms of signal-to-noise ratio, contrast-to-noise ratio, image resolution, and in this case in terms of safety. And that is what I'm going to show to you along this presentation. Starting with the radio frequency and patient eating, we have to talk about the levels of SAR and local eating and why it is important. Because the overeating can cause burns, tissue eating, and local eating in ear implants or leads. And our scanners have different modes to control the SAR levels and local eating based in International Electrotechnical Commission guidelines. In clinic, we only deal with the normal mode and a first level controlled mode. And we must be aware that when we go to the first level, we are dealing with a body temperature elevation of 1 degree Celsius. In some cases, that might pose a risk to the patient that we are scanning. And the wrong manipulation of some scan parameters can contribute for that. During the scan, we can see some alert messages about the SAR limits exceed. Here, we have two examples from Siemens scanner. And the scanner gives us recommendations and possible solutions to go forward in the examination. In these cases, we have changed in terms of the time of repetition, the flip angle, and the radio frequency pulse type. Starting with the radio frequency transmitter bandwidth that will send, let's say like this, the radio frequency pulse, we have different types of pulses that we can use. This is a Siemens scanner, and we have the fast mode, the normal mode, and the low SAR mode. We have differences between them, but before that, we have different vendors with different option names depending on the vendor that we are talking about. I only show the three major vendors of the MRI scanners in the world. As we can see, the option names are not very different from each other, and they all have the same main effect. The thing that they change is the type of pulse they use and its duration, but the main safety note is that they have options to use radio frequency pulses that will produce low SAR during the examination, reducing the eating for the patient. But all of them will raise the time of echo, and in some cases that change will contribute for the loss of signal, typical when you increase the time of echo value. So, in normal mode, the purpose is for standard operating mode, balancing the scan time, image quality, and the SAR levels. The implications into safety and image quality are that this normal mode is designed to have a good compromise between SAR, image resolution, signal-to-noise ratio, and the scan speed, ensuring the patient's safety. The applications, this normal mode is used in many situations and applications in MRI scanners. Going to the low SAR mode that has the purpose to minimize the SAR levels, reducing the amount of radiofrequency energy that will be absorbed by the patient. It is important for patients with conditional implants and devices, more important for active implants and devices, pregnant women, and neonates. This mode can reduce image quality in terms of imaging resolution and signal-to-noise ratio. Finally, we have the fast mode that aims to speed acquisition time of one examination, increasing the gradient performance, which can lead to an increase on the PNS risk. Let's compare what happens in the low SAR and the fast mode. In both, we see that we can have changes in the time of repetition and the time of echo, but in the fast mode, we have lower times of echo and repetition. We always have to take into account that the value of the TR and the TE, because of different contrasts, can pose a problem in the image quality. Sometimes, if we change this mode of radio frequency pulse time, some other parameters might be changed in order to have image quality that is good. A caution that we might have to take into account is that the fast mode should not be used in patients with implantable medical devices, mainly the active devices. Another alternative that the system gives to us is to decrease the number of slices in order to diminish the excitation of the tissues, like we see in this example. We can decrease it only to the anatomy that we want to study. For example, if we only want to study the brainstem, we can reduce the number of slices. So it is critical that the radiographer knows well the anatomy and the pathology that he's studying. Another solution is to change the time of repetition. In this case, we see a T1 turbospin echo sequences where we have to increase the TR values to that values that are running away from the T1 weighted images. So in this case, if we want to maintain this examination in the normal mode of operation and maintain the T1 values correctly, we have to manipulate some parameters like the use of concatenations, and sometimes when we change some parameters, we have to change another parameters in terms of signal to noise ratio, contrast to noise ratio, and image resolution. And it is more difficult to manipulate the SAR levels in the T1 weighted imagings than in the T2 weighted images. So for this, radiographers have to know that we have different types of images in terms of weighted images, T1, T2, and proton density. And we have different times of T1 and T2 according to the field strength that we are working. One practical example is when we pass from the 1.5 Tesla to a 3 Tesla in the T1 weighted image in spin echo sequences, we see that in the 3 Tesla we have the electric effect, we have poor contrast between the white and the gray matter, and we will have higher SAR. So we have a good alternative that is the T1 3D spoil gradient echo that is going to have lower SAR, and we have to have good results in terms of the contrast to noise ratio between the white and the gray matter. The flip angle refers to the angle by which the net magnetization vector is rotating from its equilibrium position into the transverse plane using a radio frequency pulse, and we have to pay attention when we alter the value of the flip angle that we can change the image contrast for the MRI images. So we have different techniques that can decrease the SAR values in our examination, but they have trade-offs that we might be aware, such as, for example, the rectangular FOV. We are going to use that, and we are going to have the result of lower signal-to-noise ratio compared to a square FOV. For example, when we increase the time of repetition, we'll increase the scan time, or we can increase the discomfort for the patient, for example, in the incooperative ones. And the patient position, for example, we know that the first examination, the scanner will apply a worst case scenario for the SAR calculation, and we will have higher SAR values. Going to another risk, the PNS, the peripheral nerve stimulation risk. Why it is important, the gradient performance? It's because the high slow rates and gradient amplitude cause PNS, increasing the patient discomfort and can distort the sequences. Faster gradients will result in better spatial resolution and temporal resolution, but will cause the PNS risk and the eddy currents, giving distortion to the images. And the PNS is more likely to occur in the fast sequences, such as API sequences using diffusion, perfusion, and functional MRI, when the gradient epsilon has the most significant gradient activity. The perfusion, like I said, the DTI, the high resolution images, thinner and oblique slices. Going to the different characteristics of the gradient, we have the gradient amplitude, that is the maximum intensity of the gradient magnetic field that the system can give us to us, the slow rate, the rate of change of the gradient magnetic field with respect to the time, and the rise time, that is the time that it takes from the gradient to go from 0 to its maximum amplitude, like we see here on these images. So in short, we can say that amplitude is how strong can the gradient get, slow rate, how quickly can the gradient strength change, and the rise time, how long does it take to reach that strength. And these characteristics have direct impact in the MRI images. We can use those characteristics in the maximum, and we will have a higher demands in the gradients, and we can use smaller voxel phases. We can have fine image resolution, thinner slices, but in the other end, we have an impact direct in the MRI safety, in the higher peripheral nerve stimulation and acoustic noise exposure, the increase of this risk, and we have more induced currents here. So to reduce the slow rate, we can manipulate some parameters, but the radiographer's knowledge is critical in those modifications, not only for good image quality, but for MRI safety of the patients and the devices, like the increasing the echo spacing, like the reduction of the receiver bandwidth, reduction of the matrix sizes, the increase of the FOV, but these two, the last two, we can change some image resolution parameters, so we have to take into account all of that. In terms of the gradient performance, we can see on this figure that the steeper gradient will have thinner slices because of the inclination of the gradient. The opposite happens when we use the shallow gradients. We can see a lower probability to have the PNS. Many of you have already seen alert messages about the PNS sensations on patients in your systems when you use sequences with thinner slices. The same happens when we use the smaller FOVs. Because of the higher amplitude of the gradient, we will have larger induced currents, giving us a higher probability of the PNS risk. So going to another point, acoustic noise sequence optimization. This one is one of the major factors of discomfort and anxiety for the patients. So for me, acoustic noise must be a part of safety and quality program of a safety culture in MRI department, and this subject must enter in the part of the images optimization process of the sequences in the MRI protocols. In the first graph, we see that when we use higher field strength, we can have higher values of acoustic noise exposure, but this not happens in all of the equipments. And in the second graph, you can also see that the API sequences will have higher values of the acoustic noise exposure when compared to the other ones, and the 3D gradient echoes because of the 3 gradients that are activated simultaneously to create the 3D images. This example is from my PhD thesis. We see that on the API sequences, after the shimming phase, we see the application of the multiple radio frequency pulses that results in the acoustic noise exposure with higher values, and the inversion recovery, we see phases with lower and phases with higher acoustic noise exposure. This depends on the pulse that are applied during the sequences, so the acoustic noise exposure is directly associated to the physics of each MRI sequences. The parameters, we can change some parameters that will result in the reduction of the acoustic noise, and it is important to see many of these parameters change the gradient amplitude, and the gradients are the primary source of the acoustic noise. Nowadays, in our new equipment, we have the quiet sequences. This is a conventional one, and if we use the quiet suite one with the same acquisition time, we have the same quality with the decreasing of 69% on the sound pressure level filled by the patient. It same happens in the diffusion sequences, the API sequences. Going to the C-spine, we have almost the same percentage of the sound pressure level decrease, and the same happens with a little bit higher scan time in the PD with fat suppression in the knee of this patient. Going to the sequence parameters, we all know that we have many sequence parameters that influence directly the image quality. Some of them, all of them are not shown on this image. This is the most important ones, but some of them will influence directly the contrast to noise ratio. Others will influence directly the signal to noise ratio, and others the image resolution. And In this slide, you can see the importance of the manipulation of them in some aspects related to MRI safety for SAR levels and PNS risks. Some of these parameters, for example, the type of sequences, the number of phase encodings, can affect both SAR and PNS risk and levels. Starting with the time of repetition, the image effect, we know that when we use a short TR, we have more T1 weighted images. In long TR, we reduce that weight images. Higher signal to noise ratio for T2 contrast. In terms of safety, when we have short time of repetition, we have higher radio frequency duties that will result in higher SAR. So we have to increase the lower SAR, but we have to take into account the time of repetition on the T1, T2, and the proton density weighted images, so we cannot run away from the contrast of those weighted images. Going to the time of echo, when we increase the image effect is the increase the T2 weighted imaging and the susceptibility effects. Very short time of echo favors the T1 and the proton density light contrast in gradient echo sequences. In terms of safety, it doesn't have direct effect on SAR and the PNS, but if we use longer TEs, we can have distortion in our images. The field strength that we use in our systems have a direct impact on the SAR values, like you see in the graph below. You see that the exponential growth of the SAR values when you pass from the 1.5 Tesla to a 3 Tesla scanner. When we use higher field strengths, we deal with more efficient gradients with a better image quality, like we see on these images, but we are increasing the PNS risk to the patients. Going to the flip angle, the image effect in the gradient echo, the flip angle determines contrast and signal, and the spin echo sequences too. In the higher flip angles, we have more signal until the saturation, but higher flip angles will result in higher levels of SAR. When to change, we have to reduce the flip angle to lower the SAR, but we have to take into account the contrast of the different weighted images, T1, T2, and proton density in spin echo and in gradient echo. In this image, you see when we use lower flip angles in the T1 weighted image in spin echo sequences, we might not have a good signal and good contrast like we see on these two. But if we put a flip angle of 50 in this sequence, you might have contrast of a gradient echo sequences, not in the spin echo sequence. So to have a good contrast, a T1 contrast in a spin echo sequence, you have to use flip angle 70 to 90. 90 is the great value from this type of sequences, not to run away from the contrast of this type of weighted images. In terms of the image matrix and the voxel size, they will not influence directly the SAR values, but the image effect, we have larger matrices that will result in a higher spatial resolution, lowering the signal to noise ratio. In terms of safety, we don't have a direct SAR change, but smaller voxels may force longer scan, more time the patient in the bore. When to change, reduce matrice for low SAR or difficult patients. If resolution must be maintained, consider parallel imaging and artificial intelligence, and accept the signal to noise ratio penalty in terms of the acceleration factor of the parallel imaging. In terms of bandwidth, when we increase the bandwidth, we will reduce the chemical shift and distortion, but we will reduce the signal to noise ratio. In terms of safety, the higher bandwidth has negligible effects on the SAR effect. When to change, when we have distortions in our images like we see here. We see the use of the low bandwidth and the high bandwidth. We see the time of echo is low when we use a high bandwidth, resulting in fewer distortions in the image in this patient with a sigmoid colon cancer, and it will have a negligible effect on the SAR value and the V1 RMS values. Going to the number of averages, we have the image effect, the signal to noise ratio is proportional to the square root of the number of averages. Increasing this number will increase the scan time and can increase the patient discomfort during the examination because of the duration of the examination. Going to the speed of the MRI images, it is important that we must know that the turbo factor, long turbo factors mean many refocusing pulses that will result in very high SAR. The parallel image does not have a direct effect on the safety, but only in the scan time that can helps the patient to reduce the discomfort, turning it faster. And artificial intelligence, we use fewer TR cycles, the fewer RF pulses, less SAR, and allows fewer API factors, resulting in less PNS risk. Going to this graph, in this slide, we see in the text strategies to reduce SAR that we have talked about in this presentation, and the sequences with higher relative SAR with more radio frequency deposition are the turbo spin echo and the spin echo ones, and the inversion recovery are included in this one, and the gradient echo and the APIs will have a lower relative SAR compared to the later. Going to the sequence types and the PNS risk, we see that the API sequences and the true FISP sequences are the sequences with higher demands of the gradient performance, leading to a higher PNS risk for the patients, like we see on the graph. The spin echo sequences and the 3D sequences with variable flip angle, such as SPACE from Siemens, are good examples of lower PNS risk for the patient. Going to the scenarios, the first one is the fetal MRI. We are always have to use the low SAR mode in the radio frequency pulse type because we are scanning a pregnant woman. And during the protocol, we orientate slices to the mother with higher FOV size compared to the FOV used when you orientate the slices to the fetus. In this case, we deal with thinner slices with smaller FOVs that we can increase the PNS risk to the mother. Going to a patient with a conditional pacemaker that needs a T1 weighted imaging in the brain MRI, the 3 Tesla scanner, we have the SAR limits. We have to use only the normal mode of operation, putting the sequences in the low SAR mode, and sometimes we perform, of course, the gradient echo T1 3D compared to the T1 spin echo sequences. Going to the third scenario, it's a patient with a deep brain stimulator system from an MRI and a 1.5 scanner. We see that we have many conditions to scan this patient, like the static magnetic field, the gradients performance, the SAR levels, and the B1 RMS levels, and the scan time. Because of the B1 RMS and the SAR levels, we have to pause all the sequences before launching them, not to pose a risk to these patients, and look to the B1 value of that sequence, not to overcome the B1 RMS value that is preconized in the IFO of this DBS system. So during the examination, we can see on these sequences that we have 3.6 microtesla of V1 RMS. So I have to decrease this value to 2.0 like it is performed in the IFU of this DBS system. So I can use the same techniques to decrease the SAR values. For example, you can increase the time of repetition, increasing the pulse duration. We can minimize the refocused flip angle when using spin echo sequences. This reduces the protocol B1 RMS SAR, but may decrease the signal to noise ratio and modify the tissue contrast. And we can reduce, of course, the minimum slices to a minimum. We have to put all the sequence in the low SAR mode. We have another adjustments like the reduction of the number of echoes in the sequences, in the turbo spin echo sequences. We can increase the time of repetition again and use the longest acceptable TR to achieve the desired contrast when use the T1 weighted imaging spin echo sequences. In this chart, we can see that we have sequences that are easy to reach the correct values for the B1 RMS limits, and there are classes like the ACE and the TrueFISP that are more difficult to comply these safe values. Here we have to manipulate some parameters that we have to talk in this presentation. And with this, we can safely scan this patient. Going to the last scenario, we have a patient with a pacemaker that has a limit of 2.8 microtesla with a SAR using the normal mode, and we achieve the exceeding limits of values of U1 RMS and the SAR values. These are the conditions of this pacemaker. This is the protocol that I'm going to use along the examination of this patient. So what to do? In the A sequencing, I can reduce the echo train length, reduce the flip angle, increasing the repetition time, but I will increase the apnea time for the patient. In the in-out of phase sequencing, you can lower the flip angle, increase the TR slightly, and attention to the TE in the in-out of sequences, the change of operational mode, and we can have, of course, another SAR techniques, the reduction, and it will have the outcome of ensuring the execution the MRI safely, going to the values that are lower than the one recognized in the IFU of this pacemaker. Concluding, we have to have a balance regarding MRI safety. We have to have a balance between the signal to noise ratio, the contrast to noise ratio, acquisition time, and the image resolution to have a best diagnostic image quality at the end of examination. Take always into account the MRI safety and the conditions of the patients, of the devices, scanner limitations that we have in our departments, the field strength, the gradients performance, the radio frequency coils, the type of sequences, the AI tools and the advanced techniques, and many other aspects that I will I did not talk in this presentation. And concluding, we know that we have different patients with different conditions, with different implants, with different instruments to use during and along the MRI examination to better scan those patients in a safe mode. And optimization, we have to deal with signal to noise ratio, the speed of the acquisition and the resolution, but in that the safety must enter on this graph where signal to noise ratio, the speed of the acquisition, the image resolution, and the safety of the patients must take into account to better perform an MRI with quality in all of the patients in a safe way. Thank you for all your attention.
Thank you so much, Peter. I have to say, I really liked how you went into the nitty-gritty of this intersection between safety and image quality. It was a very nice refresher to go through all those implications coming from manipulating different MR parameters like TR, TE, the bandwidth, and also understanding how this impacts all those safety aspects like the SAR, but also more like patient comfort factors like the scan time. And we know this is quite becoming a crucial topic, especially with the implementation of all these new technologies like deep learning algorithms. Perfect. We have now reached the final speaker of the day. I would like to thank him, as all the other speakers, for once again lending their expertise and full support to everything MRI. So we are honored to have here today, once again, Dr. 𝐂𝐻𝐿 for this third consecutive year. Dr. 𝐂𝐻𝐿 is a recognized authority in MR safety. He has chaired national and international safety committees, acted as a consultant to the FDA, and authored more than 150 peer-reviewed publications. He is the lead author of the American College of Radiology MR Safety Guidelines, has developed multiple educational tools and safety applications. He founded the American Board of Magnetic Resonance Safety, and also, of course, he has lectured extensively on MR safety around the world. So today, Dr. 𝐂𝐻𝐿 will continue this discussion initiated last year about remote operations, and he's going to provide us with some updates regarding this complex, but I would say absolutely fascinating topic. Dr. 𝐂𝐻𝐿, a pleasure to have you here. Please, when you're ready, feel free to take the lead.
Thank you very much for inviting me to participate in this presentation. My name is Emmanuel 𝐂𝐻𝐿. I'm a neuroradiologist at the University of Pittsburgh Medical Center. I'm the chief of the Division of Emergency Radiology and the director of Magnetic Resonance Services here at UPMC. My topic is updates in remote MR scanning, but actually it's about standardizing remote magnetic resonance scanning. In the last few years, technological advances have transpired that have enabled us to control and operate an MR scanner from a site that's physically remote from where the patient and the scanner are located. What does remote MR scanning mean? Well, until now, essentially, it's really meant that the patient is lying in a scanner in location A, and the technologist is operating that same scanner from location B. And this provides many benefits, and including the democratizing, as it were, the ability to have talented, experienced, capable, knowledgeable magnetic resonance technologists or radiographers in one location, being able to service magnetic resonance scanners and patients that are in other geographic locations. The same technological advances that enabled us to remotely operate an MR scanner, however, have allowed us more recently to focus on a capability that just a few years ago we didn't have, and that's the ability to remotely scan multiple patients in multiple different remote MR scanners simultaneously. There are already several sites in the United States who are performing not just remote MR scanning, but scanning patients remotely on 2 or 3 different sites, 2 or 3 patients being scanned simultaneously. In this article that was written back in 2024, just a little bit more than a year ago, the article already describes back then how they were scanning 2 different patients at the same time in 2 different locations. In that article, they were describing the rollout of their remote MR scanning, and they said that technologists or radiographers were concerned about compensation, that one of the things that they had done at that time was to provide a $20 per hour bonus for technologists who were performing MR scans on multiple units, multiple patients at the same time. And I found it fascinating that they specifically noted, quote, the above referenced bonus structure, which comes into play when a technologist covers more than one MRI, was received very positively. Technologists were receptive to this idea, and it has been fruitful in securing successful implementation, unquote. As you might imagine, though, to get serious for a moment, there are substantial financial incentives in order to remotely scan, and more importantly, to scan multiple patients at once. But right now, there are no really true universally accepted, I should say, standardized approaches as to how to do so. Each site or each organization who today is practicing remote MR scanning has generated their own processes, their own policies, procedures, guidelines, practices. The one thing that they all seem to share in common, however, is that in every case of remote MR scanning, there's a remote MR scanning technologist or radiographer, as well as some on-site medical professional with the patients who is dealing with those tasks, duties, and responsibilities that the remote MR scanning technologist cannot safely or physically execute, regardless of how knowledgeable they are, how experienced, or how skilled they may be. The American College of Radiology, or the ACR, has posted its own recommendations regarding remote MR scanning, and these seem to be pretty conservative, and actually more conservative than what is being practiced by many of the remote MR scanning sites today. In response to their posting these recommendations, multiple comments were made, and these seem to have uncovered 3 areas where there seems to be difference of opinion or difference of concern or level of concern regarding remote MR scanning. And these 3 areas seem to be in no particular order. Number 1, who is this on-site person? What are their minimal knowledge and skill requirements? Does anybody else need to be on site at the same time with this on-site operator? And can we safely perform MR scanning on more than one patient at a time? When it comes to who this person on site is and what are the minimal requirements, the ACR seems to be pretty clear about that. When it comes to how many should you be scanning at once, the ACR seems to have published somewhat conflicting recommendations in this regard, even within the same document. In this document from January 8th, 2025 on remote scanning, the ACR published their recommendations, and they said that the on-site qualified person must be a technologist or someone who is similarly trained, and that if the person that is on site is not a technologist, then an on-site supervising technologist must be physically present in the immediate vicinity of the scanner. Also, they should only be doing one scan at a time, not multiple simultaneous scans. This was updated on March 20th of 2025, and they refer to comments that suggested that some had questioned whether they needed to have an on-site full technologist. Some felt that they did, some felt that they did not. They also had received several comments suggesting whether or not multiple patients could be scanned simultaneously. Some said yes, some were concerned about that. And they noted that this is rapidly changing and they're going to keep watching it, but in the meantime, this is, in fact, their present stat and present position on this matter. In the ACR manual on MR safety from 2024, they said a dedicated level 2 MR personnel, that means fully trained in MR safety, should be the one who's on site overseeing the patient and in communication with both the patient and the remote MR scanning technologist. Once again, presence of an on-site level 2 MR technologist. They talked about the tech aide or tech assistants or on-site personnel, patient manager, and they admitted that this has not been standardized, so they're not going to make any statement about this yet, and they're going to wait and see how this develops. Again, they noted the remote technologist must provide undivided attention to one patient at a time for the entire duration. They actually also pointed out that in order to do remote scanning, you needed at least a minimum of 3 MR personnel, the remote MR scanning technologist, an on-site MR technologist level 2, and one more person. They also said that a dedicated level 2 person should be the one who is talking to both the patient, overseeing the patient, and in communication with the remote technologist. And once again, you should not be scanning multiple patients at a time. Under a separate section called Simultaneous Remote MR Scanning of Multiple Patients, they discuss that there are several challenges and safety considerations, and that instead of saying it's not recommended or shouldn't be done, they said that the MRMD, the Magnetic Resonance Medical Director, should ensure that the established policies and that there are established policies and that the site should provide oversight for safe scanning. And they go further and they say, since they don't have much experience in simultaneously scanning multiple patients, sites are recommended to adopt this approach only if they are confident they have developed sufficient staffing and standard operating procedures that will in no way compromise patient safety and diagnostic efficacy of the MR examinations, which is somewhat in conflict with other statements that they've made in the same documents, including this one: simultaneous remote monitoring and or scanning with more than one scanner at a given time by a single remote technologist is not recommended. The American Board for MR Safety, or ABMRS, which will hopefully shortly transition into the International Board of MR Safety, has taken a different approach on this, and it's one that's been motivated and guided predominantly by safety, efficiency, efficacy, and especially legal jurisprudence considerations. Most people are familiar with this document published in Journal of Magnetic Resonance Imaging in November 2016. And this is the consensus document of these 8 organizations that essentially defined and codified, if you will, the positions of Magnetic Resonance Medical Director, Magnetic Resonance Safety Officer, and Magnetic Resonance Safety Expert as being recommended for all places that are performing human MR imaging. This was back in November 2016. What most people don't know is that it was actually the ABMRS who first defined and generated certification examinations for these positions, MRMD, MRSO, and MRSE, back in 2015, more than a year before the consensus document for these titles and positions was actually published. It's therefore quite fitting that the same American Board of MR Safety defined what was needed for safe remote MR scanning, what are the requirements for the on-site personnel, and then generate certification examinations for this position as well. One of the main motivating problems was what we found at the ABMRS as we began to tackle this was that we looked at how remote MR scanning was happening throughout the world, and what was essentially happening was some group would say to a site, I will remotely scan for you, and you and your employees will be responsible for safety, and I'll be responsible for the scan. that has no legal legs to stand on. It's unrealistic and untenable. For example, if the patient suffers a thermal injury or burn in examination, the remote MR scanning provider, the technologist or radiographer who is scanning that patient, will almost certainly have some liability and responsibility as well. They're the ones that chose to operate in normal or first level controlled operating mode. They selected the SAR or B1 plus RMS of each of the sequences, the durations of the sequences. They accepted the patient to scan with or without a foreign body or implant or device on or in them. So of course there is going to be some level of legal liability. Suggesting that the site is responsible for safety and we're just going to do the scan has no legal legs to stand on. The remote MR scanning technologist not only can, but must accept responsibility and liability for that part of the MR practice and the examination that is under their expertise, their control, and their guidance. In a similar fashion, the MR site and its employees, where the patient and the scanner are located, they too must accept responsibility and liability for the portions of the MR examination and the safety practices that are under their control and under their guidance. What we need then is clear, prospective, and well-defined delineation of what tasks are done today by a regular MR radiographer, a regular MR technologist. What are the tasks that they're expected to do in a typical in-person MR site or MR examination? Once you generate that list, you can then identify each of these tasks line item by line item, and in a remote MR imaging environment, allocate them and assign those tasks to whoever is most appropriately responsible or liable for carrying them out in a remote environment. Some of these tasks will be assigned to the remote MR safety technologist. Others will be assigned to the on-site MR personnel. And speaking of the on-site MR person, from now on, we're going to refer to that person as the MR safety tech. This name was very deliberately chosen, not right now. At another time, we perhaps can go into details as to why and how. But the name of this person, who will be on site and will have very clearly delineated responsibilities for certain things and will not be responsible for others, this is going to be the MRST, or the MR safety tech. So what does the MR technologist or MR radiographer actually do? What are their typical responsibilities when they're scanning someone one-on-one? We put together surveys, we spoke to supervisors, we had several hundred responses, and we put together from technologists, radiographers around the world what they said. This is what a typical MR radiographer or technologist is responsible for today when we scan our patients. And we generated this list of what we divided into 22 separate line items or tasks or duties and responsibilities. We then said, in the setting of a remote MR environment, which of these would be done by the remote MR scanning technologist and which would be most appropriate for the individual who is on site, the MR safety tech or the MRST. And we then redivided that same task into technologist versus MR safety tech. Without going too much right now on this page into the specifics, turning this sheet, technologist responsibility, into what goes to the tech and what goes to the safety tech, that was a major part of our job. Once that was allocated, we could look at all the responsibilities of the MR safety tech and thereby identify what they needed to know and what they needed to do and what they didn't need to know and didn't need to do. Remote MR scanning requires that everything that was done by one person until now, the MR technologist, was now going to be accomplished partly by the remote MR technologist and partly by the on-site MRST. Splitting that up immediately introduces the potential for confusion, miscommunication, lack of clarity as to who's responsible for what. I thought you were covering that. I thought you were doing that, when we're doing different tasks and executing different activities for this patient. Therefore, as our legal counsel, we had an attorney, a plaintiff medical malpractice attorney, as part of our committee to define these tasks and responsibilities, as they immediately advised us, one of the most important things that came out of this entire discussion was that remote MR scanning absolutely mandates, it requires crystal clear clarity and contemporaneous written documentation of all communications regarding each and every step of patient care that is to be delivered by the MR scanning tech remotely and by the MR safety tech on site. Further, for all tasks that were related to the patient undergoing the MR scan, the diagnostic scan in front of us, the MR-ST is going to be just an assistant to the remote MR scanning tech. The remote MR scanning tech is the one who's level 2 trained. They know everything about MR safety. They know about the patient. They know about the modality. They understand sequence design. They know positioning, centering. They know padding. These individuals, the MR technologists, are going to be the ones that are going to be overall ultimately responsible for the proper execution of that MR study. The remote MR scanning technologist, together with the supervising radiologist, of course, will remain ultimately responsible for reviewing the pre-MRI safety screen, clearing the patient for MR scanning, accepting or rejecting implants, devices, and foreign bodies, defining the study, the sequences, the parameters that will be done, issuing any potential orders that are needed before, during, or after the MR examination, etc. It's their study, and they are expert at the MR scanning part of this study. The remote MR scanning technologist will fully direct the on-site MR safety tech as to how to position and center and pad that patient, hearing protection, contrast-related activities. All such orders are coming from the MR remote scanning tech to their assistant in this scan, the MR safety tech on site. However, for all other tasks, site access restriction, an electrician wants to enter the site and perform some repairs, managing an on-site emergency, executing an intentional quench, turning the scanner on and off in the morning and in the evening, ensuring the function of the remote access hardware and software. For all these on-site, non-patient related activities, the MR-ST is not only not an assistant, they're the only ones that are responsible for those activities. They are primarily responsible and liable for ensuring that those activities are safely and accurately and performed in a timely fashion. These used to be the responsibility of the on-site MR technologist, and these have now been inherited by this MR-ST, who is primarily responsible for those activities. For all activities related to a patient undergoing an MRI examination, the remote MR scanning technologist is primarily responsible for the safe and efficacious execution of that study, and the role of the MR-ST for imaging patients and the role of the MR-ST in the rooms that the patients are in, unless there's an emergency, they're the assistant to that remote MR scanning tech, and they serve as the eyes and ears and hands and feet of the remote MR scanning technologist. For on-site related activities not related to a patient being scanned, as well as for any and all emergencies anywhere in the MR suite, even in the case of a patient being scanned, there, the MR-ST is not an assistant. They become the primary responsible party for the safe, timely, and efficacious execution and management of those non-patient related activities or all emergencies on site. So now we immediately see that the MR-ST does not need to have any knowledge about how to scan somebody, and they therefore also don't need to be as deeply trained. The breadth and depth of their MR safety training does not need to be as much as that of a level 2 MR person. After all, they will not be managing RF, and they will not be managing gradient energies, and will not be overseeing how they're used. And since they don't need to scan, and since they don't need to have the same level of depth, less education, fewer responsibilities, and therefore they'll get a lower salary. And that may sound like I'm being cute, but not only am I not being cute, it is critical and vital for MR remote scanning to survive and grow that it's fiscally viable and fiscally responsible. So this individual will not be paid the same as a full MR technologist, of course, but rather less. As a ballpark, let's say 50% of what they're paid. To accomplish these two very distinct and disparate sets of duties and responsibilities, two major changes are now going to be introduced to the practice of MRI that we never did before. These never existed in human clinical and research MR imaging. Change number one, the MR technologists will be issuing written, contemporaneous orders to their MR safety techs, and the technologists will be held legally liable for the orders that they issue them. How do I want this patient positioned? Head first, feet first, supine, prone, padding, centering, hearing protection, all the orders, contrast orders, all of that will be coming from the MR technologist to the MRST. The MRST will be legally responsible for executing those orders that they were issued and for documenting that they had executed and carried out those orders. This process is identical to what we use today and have used forever in the practice of medicine. Prescriptions or orders from a healthcare professional qualified or trained in a given domain, and execution sign-offs by another healthcare professional who's educated and trained to execute such orders. The second major change is that the MRST needs to know a whole lot more than level 1 MR personnel, but not quite the same depth and breadth of an MR2 personnel, because there are things that they won't be controlling and not need to handling and therefore not need to be liable for. So there'll be sort of a new level 1.5 MR personnel for this MRST. Level 1 MR personnel can be left on their own recognizance but cannot supervise others in zones 3 and 4. Level 2 are exceptionally deeply trained. They can not only be left on their own recognizance, they can supervise others in zone 3 and 4, and they're trained in all areas and all aspects of MR safety. Level 1.5 MR personnel can be left on their own in zones 3 and 4, but they will also be able to supervise others for some of the energies that are used in the MR imaging process that they will be responsible for. And that will be the static magnetic field gradient, and the cryogens. Since they may, in some states, be permitted to inject contrast agents, they may have to have some knowledge about contrast agents as well. But they are not expert in and cannot supervise others regarding the time-varying RF and gradient energies that are used in the MR imaging process, and they have no control over them. In fact, the primary differences between the remote MR tech and the MR safety tech is that the MR safety tech does not need to understand the science behind the MR imaging process, does not need to know how to perform MR studies, and does not quite as deeply need to understand level 2 MR safety knowledge training. It's more of a level 1.5. They will need to be fully trained when it comes to things that are under their control, such as the static field gradient, and cryogens. In the past, we've had a medical director, an MR MD, an MR safety officer, MRSO, an MR safety expert, MRSE. We are now introducing for the first time a fourth such position, the MR safety tech, the MRST. The American Board of MR Safety will be presenting an online event which will consist of a presentation and a major announcement regarding standardization in remote MR scanning, as well as the MRST position. This will take place on December 11, 2025 from 10 a.m. to 11:30 a.m. Eastern Time and will be intended for an international audience. Please stay tuned for more announcements that will be very shortly forthcoming in the next few weeks. I'd like to close by just saying two more points. Number one, remote MR scanning is here to stay. Now, at the infancy of remote MR scanning, this is the perfect time for us to ensure that we implemented correctly from the get-go standardized, well thought out, well-defined safety oversight structures for remote MR scanning, whether we're providing scans to one patient or multiple patients at a time. I'd also like to point out that the Federal Aviation Administration in the United States is shortly going to be approving flights where the customer gets on the aircraft that you see in front of you, it takes off and it lands somewhere else, and the customer gets off, and the pilot has never been on that aircraft. What they refer to as autonomous air taxi is explained as, quote, when we talk about autonomy, of course what we really mean is that we are taking the pilot out of the aircraft. But there is still an operator involved in the system. That operator is on the ground instead of in the cockpit, unquote. In a society where we are going to be seeing people getting on aircraft and getting off aircraft and the pilot's not on board, I think it's safe to assume that we will also be seeing dramatic growth in remote MR scanning. Establishing standardization and certification will be critical steps in helping us do so reliably, efficaciously, efficiently, and most of all safely as we move forward into our collective futures. Thank you so much for your time, and thank you for your attention.
Hello, everyone, again. Me and Julian are back. This was an amazing presentation by Dr. 𝐂𝐿. Thank you so much. We'll have a lot to talk about remote, and I'm glad you're all here today. I want to start by apologizing to the lectures today because the quality of the lectures wasn't great, and it's because the Zoom was compressing the files. They're big files, around 5 GB or more. And that's why the quality wasn't there. And I want to personally apologize to you guys for taking the time to be here and doing such amazing presentations. And we were not able to provide the best quality possible. So we like to be transparent and say that it wasn't on the lecturers. It was something that we couldn't control. So just to everyone to be aware. So we've been promising 2 announcements, and I'm proud that we're here today with around 350 people after 2 hours and a half of lectures to do these announcements. The first announcement is we have already a cardiac course that all of you probably are aware of. It's been running for a year now, but we decided to go a step further, and that's where the raffle that Julian posted on the chat comes into play. So I'm going to share quickly with you our site, the new site that we're going to have. I hope you can see it. So we are basically creating an online MRI university. We call it Everything MRI Academy.
I think you need to zoom it a little bit. I think it's quite zoom at the moment. I think if you can just make it a little bit.
To do what, sorry, Julian?
Yeah, just to reduce a little bit the size of the whole page.
The actual site?
No, just the size of it. I think it seems. Yep, no, we don't see it anymore. It looks like it's very zoom at the moment on it. Oh, perfect. That looks
right. Sorry. So yeah, as I was saying, we are doing an MRI Academy. The idea is that we'll have several courses all focused on MR. We want to teach the community around the world about everything that we do in MR because we are everything MRI. So we have, of course, this is a temporary site, but we have the cardiac course that all of you already know, or if you don't, we have it available. We have different modules. This has been a very successful course. So far, we have discounts. Don't look at these prices, they've changed, and we do discounts for companies as well. And we are also releasing 3 brand new courses. So we have a basic MRI course there. Actually, we have Bill Faulkner, Tobias Gilk, Victor, all of them are here, and they are part of Eric, I believe, as well, and they're all part of the lecturers on this course. We also introducing this new introduction to remote operations. So we'll talk about remote scanning, how it's done, the roles, the responsibilities, as Dr. 𝐂𝐿 was saying, the liability, the legal aspects. We're going to show examples how it's been done, case scenarios, cybersecurity, cyber attacks. We're going to mention all of those things in this introduction to remote operations course. And of course, we have our veterinary MRI course, which is fully sponsored by 𝐂𝐿. We had a few requests about veterinary because there's not much information out there. So we decided to tackle these 3 to begin with. So we will have 4 courses there. And starting next year, we'll add more courses, eventually safety, MSK, body, MRI. So we'll add more and more and more. The idea is that we have a full online university. This will be our brand new site. You can access through phone, tablets, or whatever you want. So this is the first announcement. The MRI Academy will be out soon. It's not out yet. It will be out soon. And the raffle basically is if you post a picture of this event, we still have the whole round table, so you have time. If you post a picture of this event, we will give you free access to the winner, of course, to the introduction to remote operations. That's a given. And then you can choose one of the other 3 courses, either the cardiac, the basic, or the veterinary. So at the end, you will have access to 2 free courses valued around 600 to 700 pounds. So what you have to do basically is take a picture of you or of the event, just share it on LinkedIn or other social media, tag us, and we'll do a raffle. And we'll do that raffle, not live, but we'll film the raffle going on, and we'll announce the winner later on this week, and we'll give you full access to 2 courses that are worth around £700. So that's the main announcement that I have to make. There's another one that I know Julian is anxious to put out there as well. It's something that we're really proud of. So Julian, I'm going to pass it to you before we go to the roundtable. I think the announcement you're making is also really good. So please take the head now.
Yeah, just very briefly, because I can see there are plenty of questions to discuss on the roundtable. So, as probably some of you noticed on our social media page, we had like an amazing trip to Germany, and we can now reveal, well, I would say we already revealed, but we can finally say that we were there for a journey, for a collaboration with Siemens Healthineers about a documentary about the entire MRI journey, specifically within Siemens. And because of that, we have a little teaser that we're gonna post, which is gonna explain a little bit what we are doing and what you're gonna see on our social media in the next few months. So let me see if I can share it and make it work properly. I hope so. There we go. I hope you can see it.
Look at that. I still kind of believe we'll have the opportunity to speak with those these amazing Siemens Healthineers employees, those that contribute on a daily basis on the manufacturer of the mass scanner.
Just the fact that we're talking to some of the pioneers of this technology is just so exciting. And we just, 2 years old in terms of company, and already here.
I can see you're a little bit nervous, right?
I'm always nervous with cameras and stuff like that.
Yeah, you don't like them, right?
I hope they're on time anyways.
Just to let you know, I think the camera is right there. Yeah, sorry.
Yeah. Hi guys. This is the project that we've been hyping you up about. We are at Siemens Healthineers headquarters. And actually what we're doing is a 3-part documentary about what Siemens has been done, what they're doing now, and what they're going to be doing in the future. But I think Julian has a few more words about these 3 episodes.
Yeah, it is exactly as you said. I think we're going to have this fantastic journey starting from the present, seeing where the MRI is at the moment within Siemens Healthineers, and then jumping back into the past to see what was the first design of the MRI scanner. And then, of course, we all know you're interested about new technologies.
Yes.
So future will be quite a big thing. Are you ready, Sam?
Yeah, no, I think I am. So let's do this, yeah?
I would say let's do it. Let's jump on it. Guys, stay there. We'll see you very soon.
Thank you.
Funny enough, I lost the glasses, my eyeglasses in the meantime. I regained my eyesight. Cool. So I think we are all ready to go to the juicy part of the event.
Yes, absolutely. Just to say that this documentary will come at the beginning of next year and will be in 3 parts, so we'll take a little bit, but just stay tuned because we're very excited about what we've done there. Okay, so I will start with a question that comes directly from one of our sponsors, COP Development. So I will actually share it as a poll because I want not only all of you to answer, but of course the experts on the panel too. So the question is why there is no established dress code for MRI technologists. So the biggest pushback that they got when they installed their N3A ferromagnetic detectors that most of the times could prevent projectile accidents is the fact that the technologies, attire and accessories like watch and bijouterie and glasses, they're all there. So there's not a standardized kind of setup for the dress code. Do you have any established dress code for MRI technologies in your departments? What are your thoughts about this? I will start with Erica from UK, the ladies first. So Erica, I don't know if you want to jump in and tell us what you think about this. I believe in UK we have it. Everywhere I worked, we always had standardized uniforms because we have it for nurses, for doctors, for radiographers. So do you want to share a little bit of your experience?
Yes, so in the NHS we tend to have, there is a national uniform, but that's changing slightly, and definitely within our trust there is a uniform standard. So we all dress the same, we all look the same, no jewelry, no smartwatches, very, very standardized dress. It looks better, it looks more professional, but also it's safer. So we don't have to worry about people, with bringing things into the magnet room. And of course, mobile phones, keeping them out of the clinical areas. Yeah.
Victor, do you wanna tell us a bit about Portugal? You're based in Portugal, so Eric is giving us a little bit of what we have in UK. which me and Julian also have that experience. But you are in a different country, part of Europe, so we will have a few perspectives, UK, Europe, and then I'll jump to the US guys. So can you tell us a little bit about what you think happens in Portugal and maybe the rest of Europe, because you have knowledge about that too?
Yes, in Portugal we have the same like Erica, and in UK we have different colors for different professionals. Radiographers have one color, nurses other, clinical doctors have other color, but we found, and for example, I can say in my institution, sometimes we have some resistance in terms of the dress code, because sometimes not only from resistance from the professionals, but for example, we don't have clothes in our institution, but we have that. We have the policies. We cannot enter, of course, and we cannot work with mobile phones, with smartphones, with smartwatches and other stuffs like that. But of course, we have a dress code, but we found in some institutions a little bit of resistance, and then it might be a problem.
Do you believe, where do you think that resistance comes from?
It comes from the, I can talk only about my institution. There is, it's not quite a, it's a resistance, but for example, the safes that where the professional can put their personal belongs. Sometimes we don't have those in our department. We have to go to the other part of the hospital to put that clothes because we have their safes, but sometimes we have to walk 10 minutes from that part to our institution. So we have that type of resistance from the main top of our hospital, not the main logistics. But of course they have the dress code. They have the care and the cautions that we have to have in our department, of course.
Okay, perfect. Doug, would you like to jump in? I think you would be valuable. You would have a valuable opinion on this because you are on the university side as well. So I would like to understand a little bit from that perspective how you see this question.
Just before that, I just want to mention that Gio also mentioned that he's also asking about bras with metal underwears. Say, what about bra? So I think probably Doug can touch base on that as well.
No, thank you. I'm a component to this just because it just takes another segue out of bringing things that we don't want into Zone 3 and Zone 4, especially Zone 4. With my college, we do have uniform for all of our students. We have things where they can lock up their belongings, or we have a space for them so they can have their belongings, especially cell phones. But we also have it in our policies and procedures, about bras. I know that's the first thing that we talk about before we even have them go into lab is, can't wear anything metal, all the things that we actually have a checklist that we go over. And just again, to make it safe, we're dealing with brand new students that have never, they're basically just got out of their general educational classes. So we do start our lab pretty early. So it's really important to hit that right off in the beginning, and then also including our new MRI safety course that we have right when they start school as well. So, and we break all that down and start that day one. But uniforms, I'm a component with. There are a few facilities here in Arizona that I know of that are strict on their uniforms, pocketless, so they don't bring, that cell phone thing I know is a big deal. They forget about it, or they forget about the pen or whatever in their pocket. But I am a big component of it.
Wonderful. Actually, in UK, I used to have uniform, and Erica has raised the hand, so I'll pass the word to her. But I used to wear uniforms in UK. I don't know about you, Julian, but my uniforms always had pockets, and it was one of the things that was like, what's the reason to have a uniform if I have pockets? Because people will put things in those pockets anyways. So we had breast pocket and the side pockets as well. But Erica, would you like to jump in again?
There's just I forgot the main reason also, especially in our facility, is infection control. So the uniform is not to be worn outside of the hospital at all. So that's the biggest thing, protecting our patients. But yeah, like yours, ours also have pockets, so it's still a bit of a hazard. Yeah.
Yeah, I one of the things that I hated the most in UK was to be outside of the hospital in a bus full of
Yeah.
people and
Yeah.
see a nurse with their own uniforms on.
Yeah.
And I was like, how is this even possible? So that's a great point that you're making, because infection control is also a safety problem. And we tend to talk about safety only in terms of the three main energies that we have on MR, and we forget this because infection control is also a big issue. Julian, I don't know if you want to jump in, but I have another question already.
Well, I think we need to carry on, but I just wanted to say that what about that support, that structure to hold the badge, that kind of little thing that most of the time has a metallic component, and when you put it in your pocket, it's like, okay, I hope it's not going to fly today.
Badge, yeah. I've
Yes.
seen my badge at the end of the board a few times, to be honest.
And how scary is that? Well, anyway, let's not think about it.
But you are just to close this topic because we have to move on.
Sure. Yeah, just real quick. So for all of our MRI students, we actually have a different colored badge to kind of separate everybody out, because we don't have anything metallic in there. So that's just one more step that we did to protect not only them, but whoever goes into the scanner.
Absolutely, yeah. I have I have a question that will basically go to the three other speakers that didn't speak yet. On this roundtable, it goes to Tobias, William Faulkner, and Dr. Canal. You can answer whenever you want, but it's about, because this question came a lot on the Q&A, about the responsibility of the radiologist towards the patient in terms of safety, how they make that decision if they don't have safety training. Most of these radiologists never heard about these implants, probably don't know anything about MRI energies or anything. I had my own radiologists asking me, well, I don't know what to do. You make the decision. I'll sign it underneath it. So this is a problem that I believe we have in many, many countries, if not in all of them. I know in Italy, for example, it's the same thing. We have a radiologist that makes those decisions, right, Julian? But probably they don't have that training. And we as radiographers are struggling with that training. So I can even imagine the radiologists. So to the three of you that are involved in writing these documents that everyone follows, these guidelines, and have heavily involved in this kind of dealings, I would like to ask you, how do you see that going for the future? And how can we ask these radiologists to take that leadership if they don't have that basic training as well? I don't know who wants to take the lead and answer first.
Be glad to start it off. I will point
Amen.
out that things have changed, and there's no question that there is more education going on now than has gone on in the past with physicians. I know the point has been made, but I'll say it again to everyone who's listening. Magnetic resonance is, I started out in surgery, I went into medicine, then I went into radiology. There is nothing I've done that is as safe as magnetic resonance. And we have these courses that we've put together on MR safety, and thousands of people come to these courses. It's the safest test just about that I'm aware of that I've been involved in 3 different specialties. Why do we even have these? We have these because if no one's getting hurt, why do we need these? The reason we need these courses is because the people that do get hurt, virtually 100% of the time, it would have been avoidable.
Mm-hmm.
And as a result of that, there's a reason to teach it. But let's not make a mistake of thinking that injuries are all around us. Tobias did a wonderful job of trying to separate frequency and severity. The frequency of injury in MRI, significant injury where there's a significant patient trauma, is so unbelievably small that in any other area we would have ignored it, except that the severity sometimes is inexcusable. And when that happens, it reaches international news. And when that happens, everyone says, you're not doing your job. Well, they're doing a darn good job because just about nobody's getting hurt. So you need to understand the discrepancy that exists. In the United States, magnetic resonance is considered a medical imaging procedure. And therefore, like any other medical procedure, the safe execution of that procedure is entrusted to a physician practitioner who is trained and, more importantly now, licensed to execute that procedure. And as long as nothing goes wrong, you're doing a great job. In the extremely rare circumstance that something goes wrong, in the United States, it is indeed a very litigious society. Here, it's just a matter of time until some attorney will be looking for where is the physician that should have been overseeing the safe execution of this medical imaging procedure. And that's why it's so hard to get the physicians on board. It's nothing to do with laziness. It's nothing to do with not having the intelligence, not even being too busy. There's so many things we're too busy for, but we still manage to find time for them when they're important enough. This didn't reach importance typically from most sites because we're not hurting people in most sites. When the injury occurs, unfortunately, by then it's too late. And then the physician is the first time they typically find out you were responsible all along. And so enough of these cases, word of mouth, start to get around, then it slowly trickles into the vocabulary of the average American physician. This is something you're responsible for. And once they understand that they're truly responsible, they'll come on board on their own. In the courses that I give, the largest, by far, the largest growing segment of attendees in my courses, clearly as physicians. So it's only taken 4 decades, Samuel, but better late than never.
Do you think it's a lack of awareness mainly?
Yes, yes, absolutely.
Julian, take note.
There's a lack of awareness of 2 things. There's a complete lack of awareness of the potential to injure patients, the type of injuries. Everyone's aware of having a sledgehammer fly in. And so they're pretty careful not to bring sledgehammers. Beyond that, there's not much knowledge because it's not something we come in contact with on a normal day. You can go years without a significant thermal injury in the average MR site. Number 2, gradient energies. We talk about it a lot. It's a non-issue. It's a non-issue. Even with implants, the technologists and radiographers control the environment successfully enough that how many times have you heard of somebody having unintended cardiac stimulation, the single biggest risk of gradient energy? It ends up being that the auditory concerns by far are the greatest gradient concern, and we manage those. So by the time there is an injury, it's too late. And then the physician finds out because of an attorney, you were responsible all along, Dr. 𝐂𝐻𝐿. Where were you at the time? Why didn't you prevent this from happening?
Absolutely, Julian. I think we need to add this to our content. We need to get a radiologist.
Definitely one of the suggestion.
Toby, I think you have something to say, please.
Yeah, I wanted to add that if we look at clinical MRI and sort of the changes that have taken place in the last 25 years, 25 years ago, and all of our young radiographers are probably completely unaware of this, and it might strike them as odd or even unbelievable. 25 years ago, every MR system operator's manual had big, bold print disclaimers saying, you will not put a patient who has an implant, a foreign body, a piercing, a tattoo, you will not put this patient inside the magnet. And so 25 years ago and prior, the complexity in terms of managing patients in the MRI environment was significantly lower than it is today. If we ruled out all of the patients that were de facto ruled out 25 years ago as MRI patients, we would see volumes in most hospital settings cut in about half. So about half of our MRI patients have, these complexities that were unheard of in clinical MRI in a widespread use 25 years ago and longer. So the question was specifically around radiologists and how do we help them? We have to recognize that today, in most countries that I'm aware of, we don't have continuing medical education or CPD requirements specific to MRI safety for radiologists. And so those radiologists who are now, sort of the gray-haired, wizards of their practices, many of them went through their training at a time when these complications simply didn't exist. And so I think it's incumbent upon these radiology practices to, if they're not all going to democratize this knowledge and all share it, identify distinct individuals, MRMD designees, who are going to do the heavy lifting on behalf of the rest of the practice.
Thank you, Toby. I think Manny wants to jump in once again to finish the topic, I believe. Sorry, Manny, your microphone is off at the moment. Sorry.
Thank you. I just wanted to clarify, I disagree a little bit with Toby on this one area. This has never changed. We have had patients with shrapnel. We have had patients with implants forever. It has changed mildly in that some of the implants, which were, you will never do a pacemaker patient, we started to do pacemaker patients, and now we're doing a lot of pacemaker patients. But implants, the Toby's 100% right. The MR manufacturers, the manufacturers of the devices, that the MR scanners, they used to put in their instructions for use, do not scan to protect themselves legally, do not scan patients with implants, foreign bodies. But yeah, but that's complete useless trash to people like me, because I have patients, and 38% of my patients about 2 years ago had something on or in them. And so we had to end up taking the medical legal exposure of what's best for our patient. It may say don't do it. That's just to protect them. Their attorneys are talking to protect the manufacturer of the MR devices. But I started MRI in 1984, and since 1984, we have been scanning patients with devices and with implants and with foreign bodies. What's changed is our understanding is advanced, and there are many more active implants today than we had in 1984. It's not just pacemakers or defibrillators today. Therefore, this hits us more frequently today than it did in the past, that it goes to the attention of a physician. But in the past, please forgive me, in my opinion, in the past, as it is today, for the exquisite majority of cases of patients with something on or in them, in the United States, the physician does exactly what she or he has always done. They turn to the radiographer, they turn to the tech, and they say, is this okay? Is it all right? Then just go in there and do it.
There's actually a question, Manny, that we have from Sohaib Akhtar. He's talking about off-label scanning. So he's saying off-label MRI scanning is sometimes unavoidable in clinical settings, particularly when patients present with implants or devices that are not explicitly labeled by MRI conditional. And they ask if you can elaborate on the recommended risk assessment process, documentation practices, and multidisciplinary considerations that should guide decision-making in such off-label scenarios. So basically, what is the workflow? And the question is for the room. I see Erica wants to speak as well, so I'll give her the chance. But the question is to understand the workflow when you actually need to scan an off-label implant. Erica, would you like to?
I think it's important that you take into consideration that there may be very significant differences in different countries around the world in how this must be approached. In the United States, off-label is an exquisitely routine practice, depending on the patients, depending on the population. And I have an hour-and-a-half lecture on this in my courses of what does it mean to be off-label. In the United States, off-label simply means the manufacturer of the drug or device is not allowed to claim safety for what you're about to do. So off-label may mean you must be wearing a blue shirt when you execute this procedure. The physician may choose to put on a green shirt. It's not that it's safe. It's not that it's unsafe. It simply means, from a regulatory point of view, the manufacturer of that machine cannot claim that when Dr. Canal puts on a blue shirt, it will be safe. What they say about blue shirt is no claims are being made about putting on a blue shirt. We are only claiming green shirt. And that claim is approved by regulatory. And in the United States, it's exquisitely important that you all understand the label is never, ever intended to tell a physician how to practice medicine. It's there to regulate marketing. The label is only there to keep the companies that are selling this drug or device, keep them honest. They want to make a claim, this cures cancer. Super. Show me the data that says it cures cancer. I, the regulatory agency, will review it. And if I agree, I will let you claim it for marketing purposes. It is never meant to be the sole source of telling a physician how to practice medicine.
Thank you, Manny. Eric, I think you had your hand raised.
It was just that I think we kind of went past it a little bit, but it was just listening to all the other. I'll be very quick. There were 2 points really, and I think it's something we've spoken about before. What's changed over time, and I've been in MRI since 1984, and the difference is now is that MR is everywhere. And it's the only machine in a hospital that can be catastrophic. It can kill people. And that message is still something that very few people understand. So, and again, the most recent fatality could have been avoided if they were following safe procedures. So this is about culture, and it's about, before we talk about implants and everything else, the most catastrophic event can be because of that static magnetic field and the projectile effect, and we have to safeguard the environment and we have to restrict access. And the most recent failure was because there was someone within the MR environment that shouldn't have been there, and if they were there, they should have been metal checked. So we start there, and that's what I wanted to say, really.
Actually, we had this conversation during our podcast that is going to be released soon, and that's something that I also say, that I believe that MRI is the only machine that by entering the room you can actually die. It sounds alarming, but it is a reality, and we've seen that not long ago with that case in the United States. But we still have that narrative, not only in the media, but also within our community, that the MRI is the safe modality. So it's also something that we as a community also have to work on, because that there's still that stigma that MRI is safe. But it is safe if we follow the guidelines that are there to make it safe. So I agree 100% that MRI can be the safest modality if we follow those rules. But most of the times there's something there that makes us not following those rules, and there's 100,000 explanations for it. But yeah, I totally agree with what you're saying. There's a few more questions, Julian. I don't know if you want to pick one.
I just want to pull a little bit. Some of the other speakers, they've been a little bit quiet, like Bill, Tavai, and Doug as well. But there has been a massive discussion among the questions, especially between the relationship between radiographers and radiologists. So I think kind of like Doug's presentation triggered the whole discussion, and then it evolved talking about remote scanning. So I think there was this very interesting question, which was from Pedro Violindo, which says, in recent times, we've seen a growing trend of MRI examination being performed through remote access, with operators sometimes controlling two or even 3 scanners simultaneously from a central location. Considering that this practice significantly changes the communication flow between radiographers and radiologists, and might introduce additional risks in terms of patient safety and incident management within the MRI environment, what are the current technical and regulatory recommendations? So I think it will be interesting to hear both the perspective from radiographers and radiologists here, or anyone that wants to jump in anyway. Shall we start with Doug? You started with the discussion about this tricky relationship.
Yeah, no, I mean, with remote, it's a little bit different. I mean, it's the same. I always have, in the departments that I have been in, I always had a speak up policy. And I really believe that has gone away a little bit, just from just the feedback that I've received over the last few years, especially with COVID. Staff should have a structured and non-punitive pathways to raise MRI safety concerns, such as having that access to the MRMD or the MRSO, with clear assurance against any kind of retaliation. And this will ensure that technologists can escalate things without any fear or any disciplinary action. I just believe there's been a loss of that communication somewhere, and I don't in many places don't have radiologists on station anymore because they're at home or they're reading. So that is also a factor. So, but that doesn't mean that they can pick up the phone, or most are, communicating by the computer. But they need to build that relationship right away with the radiologist. So if they have any issues whatsoever, they have that direct connection with them, and it's all about communication. Communication's been a huge thing, part of my career. And if you don't have that communication, then that chain link that I was talking about before in my talk is going to be broken, and that's when we have accidents that happen. And then I'm not saying, like the New York accident, but any kind of adverse event can happen if you don't have that communication.
Yeah, I'm really glad we mentioned this. Actually, communication is key, and actually, the immediate next question was exactly about this. It was a question saying how to bridge the gap between radiographers and radiologists in our hospital settings, where a radiologist is not readily available, especially regarding responsibility for decision making. Now, perhaps this is a radiographer where it's kind of like lacking to find who is going to guide him regarding safety decisions. And in some countries more than others, sometimes I witness myself, is a little bit more difficult, to find a radiologist who's going to perhaps guide you a little bit, or is going to take that decision together as a part of a multidisciplinary team. So I'm not sure if maybe Bill wants to mention anything about this, perhaps jumping on this, or anyone else who wants to join on this.
Well, no, I mean, I'm, listening to everybody's opinion here, and I, hear a lot of good views. I think going back to what Manny was talking about with the MRST and the whole point of the ABMRS is this standardization and, credentialing. If you approach everything from a standardized, organized, structural setup, I think that's, what you've got to have in place, rather than try to make whatever you're doing fit the situation. I think you have to look at the structure of the organization, the roles and responsibilities. That has to be clearly laid out, because you can walk into a lot of sites. And I mean, I've been to sites where literally I was talking with the radiologist, and he asked me, he said, who's the MR medical director here? And I said, well, I was told you were. He said, I am? And lo and behold, he was. Again, I just think it's going back to something we were talking about earlier, people with accidents, people don't like to change. And people get in this. Last year I did that talk on normalization and deviation, maybe it was the year before, I can't remember, but it's still the same thing. Getting away with something doesn't prove safety. And if your safety is based on the fact that your safety based on the fact that I've not hurt anybody, or everything's worked fine up until now, that's not necessarily going to work. And remote scannings, you've got to take all this into consideration as well.
Before passing to Manny, I have one question about their MRST role, but I'll let Manny Canal reply first. Please, Manny, go ahead.
Thank you. The key about remote MR scanning is that it's no different from in-person scanning. It's just forced us to allocate liabilities that you didn't realize you had all along. Mm-hmm. In some countries in Europe, radiographers are permitted to make decisions as to whether or not to administer contrast. Radiographers can interpret studies in some countries. In the United States, they have no such authority. So when we put together remote MR scanning, we try to keep a global view and identify what has to happen from the beginning, middle, and end when a physician says, I want an MRI examination on my patient. Until that study is submitted for interpretation, what has to happen? And we broke that down into 22 line items. Someone had better be responsible. Don't tell me, don't point fingers at me and I'll point fingers at you. That won't work. And although it's got a lot of negatives to being such a litigious society here in the United States, one of the positives is that it forces focus on detail, on responsibility, on liability. Whose job is it? Why weren't you doing your job? And so I don't know if this group is aware, in the Examination Specification Committee in the American Board of MR Safety, we put together, it's not the MRST, it's remote MR scanning. How are you supposed to do it? What do you mean you're in another state? In Europe, it's like saying you're in Germany and you're in France. Have a nice day. Whose laws, literally in the United States, we have 50 sets of laws. Whose laws govern the execution of this study? Are they federal laws? Are they state laws? Who is responsible for what step? That's been brought to the forefront. One of the members of our committee is a plaintiff medical malpractice attorney to ensure that liabilities are prospectively identified before any injuries could occur. Who's going to cover what? And I saw one of the comments. It was a wonderful question. I can't believe all of you didn't ask that same question. Written orders? How are you going to get written orders when you're in Belgium and the person being scanned is in Sweden? Mm. Well, if you haven't figured that out, why are you scanning them remotely?
Absolutely.
If something goes wrong, how are you going to prove who said what to whom? Please forgive me for the boldness of the next statement. There's no one in the entire planet today that has been involved in as many lawsuits alleging injury in the magnetic resonance environment than I have. I'm approaching 500 cases that I've been exposed to professionally in the last approximately 45 years of my career. And easily a quarter of them, each one is pointing at, I never told you to give contrast. Well, I would never give contrast without you telling me to. Well, I don't remember saying it. Show me where I put that in writing. I didn't say scan that patient. I said scan him in low. I didn't say you should be in first level controlled energy mode. I didn't even say normal. I said you should do it in low SAR mode. No, sir. I remember you saying you wanted it done in 15 minutes. I had 3 patients waiting. You said do it in first level. If you haven't done it in writing, who said what to whom? And the person that's being exposed is the person who everyone knows pushed the button. That means all of you listening in right now, if you're the radiographer, you're the one being set up for failure. Because all I have to say is, show me my name in writing. When did I tell you to do that? You must have taken that decision on your own. Since remote MR scanning clarifies that there needs to be responsibility, and putting it in writing is a way to document it, all of a sudden, each of us is held responsible for exactly what has to happen for the patient to be safely scanned. Step by step, who's responsible, who executed each step. All of a sudden, we're now taking care of our patient, and nobody's wondering who's watching the store. That's why I believe it has to be in writing. That's why in the United States, it can only be executed in writing. And I'll close by saying in the legal profession in the US, there's a common saying, if it's not in writing, it never happened.
Manny, I have to add as well that all the remote operations that we've been involved with, that's the first step. It's a three-party kind of contract. Is the hospital, is the radiographers, if it's an operation that is being hired, and of course the provider of that remote operation. So it's kind of a three-part contract that needs to be signed specifying those rules and responsibilities from the get-go. We don't allow any remote operation to start without having all of those agreements in written, because for that same reason that you're explaining, because at the end, if we are starting a remote operation without having setting down those rules, we're going to be caught up in the middle of the road without knowing what to do. So that's exactly, I've done a presentation about this exactly. We have a few steps before we actually implement an operation like that. And the first one should be, do I actually need an operation like that in my hospital? And then is a risk assessment, and the roles and responsibilities have to be allocated properly. So in Europe, that also happens. We don't have a society that is so litigious like in US, but that point of view is already very ingrained in the way we implement these operations in Europe as well. So I'm quite aware that that's extremely important, and we should be all thinking about that first before we even think about implementing or scanning a patient remotely. I don't know if anyone in the panel has anything to say about that. We have a few more questions before we close. Julian, do you want to pick another one, or do you want to?
Yeah, well, I got another one, but I'm afraid it's gonna spark a lot of discussion. Probably too much, which means it's gonna last another hour. Okay, let's go ahead. So I will give it a go. So Solomon say, can you explain the reasoning behind prioritizing the radiologist authority in MR safety screening over that of the MRSO or MRSC? Given that the MRSO and MRC have specialized training in MRI safety and risk management. So I think it's a very good question, to be honest, because even in Europe, and I will take it like from a perspective slightly outside the US environment, we're kind of like awaiting in some countries to get this MRSO and MRC professional profile. We would like to see more job adverts for that. And then perhaps at some point it's going to kick in like a little bit more as it is at the moment. And then we're going to soon realize perhaps that ultimately it's going to be the radiologist's decision despite all the training, the studying pathway. So it could be a little bit, not disappointing, but a little bit, discouraging in a way, even if you are the safety expert, perhaps, that could have that final decision. So, okay, Dr. Canal, please, just give me like positive thoughts about this.
Thank you. I love the question. I have gone on record for years as saying that the radiographer is not the last line of defense. They're the only line of defense between patient injury and no injury. It's the brains, the experience, it's the practical knowledge. It's the radiographer is worth their weight in gold. So why would I not just give you the decision? And I really hope that you all take this in the spirit with which it's given. So please listen really carefully, because this may be the last time you're ever willing to listen to me. None of this is about MR safety. If you're thinking this is about MR safety, we've already lost you, and we have failed you before we even began this meeting. This entire meeting is not about you. It's not about me. It's not about safety in the MR scanner. You have missed the entire point if that's the question. This entire discussion is about my patient. They are everything. They are the beginning, middle, and end of this discussion. MR safety is a critical component to the discussion, but now listen carefully, please follow, because you have no idea how critically important you personally are to me. You provide me, the average radiologist. I believe you know more than we do. I believe the average in the United States for sure, I think it's even more so in other countries, but certainly it is extremely common that the radiographer, Bill Faulkner, Doug Boyd, you got to be kidding me. Find me physicians in the United States that are at their level. So why aren't they making the decision? A brilliant leader surrounds themselves with even more brilliant people. The concern here is what is best for my patient. And every single thing you can do for me in this entire Everything MRI lecture, all you can do is tell me what the risks are. All you can do is help me quantify How much of a risk is there if I put this person in with this implant, this foreign body, with anything? As Erica was saying, just putting them in there is a risk. You can quantify the risk. But I don't care about the risk alone. I care about the benefit to my patient. I have to do a benefit-risk ratio analysis. I need to know what my patient's best interests are. I know what the potential benefit of the MRI is because I know whether he's going to go into surgery or they're going to go into thrombectomy or are they going to go to hospice and above all, do no harm. I may not know the risks, and I will turn to you to teach me the risks if I'm the average Joe six-pack radiologist who just wants to do a great job and go home at night. But this is my patient. In the United States, it's very different. I turn to my radiographers. I say to them, this is my patient. Don't ever get between me and my patient. Help me, teach me, guide me, then get out of my way. Because I have to focus on my patient now. And I will take everything you've taught me and I'll discuss it with this patient. And if they're not conscious, I will make the decision for that patient. And it better be based on good information. And that's why I need you. Because I know what the potential benefits are. I need help with the potential risks. And that's the job of the physician. And what we have in the United States, at least, what we have been licensed to do is risk-benefit assessments, whether it's diagnostic or therapeutic, is to know what's in the best interest of our patient. If the patient's an outpatient, an elective procedure, speak with them, talk with them, guide them, and they direct their own care. And I try to translate the benefits and the risks to them, and they ultimately choose. But I'm an emergency neuroradiologist. All I see are emergencies. All I see are motor vehicle accidents. I see aneurysm ruptures, strokes, trauma. Did I mention trauma? These people don't make the decisions. And so I need you to guide me for what the risks are. And then I look at the potential benefits. And then we do what's best for that patient. And it's the medical knowledge that requires both sides. And the doctor may not know as much as you know. And they desperately need your help to guide them. But the final decision and the liability and the repercussions of that decision are shared with that patient and that physician.
I think that's the importance of the multidisciplinary team and knowing the roles, having clearly defined roles and responsibilities. Absolutely. Sam, is there anything else you want to?
I would actually like to involve Vitor on this one because he's sorry, Vitor, to bring you to this fight, but you actually involved in creating the MRSO, correct me if I'm wrong, training for Europe as well. So I would like to hear from you a little bit. What's your thoughts on this, the MRSO role within this multidisciplinary team, as Dr. Canal and Julian were just talking about?
Thank you for the question. I think I am involved in the consortium, in New European consortium about creating a curriculum from the MRSO, MRI safety officers here in Europe, because in the majority of the countries in Europe, we don't have that role. We have, for example, in my institution, and I think in UK, in the Society of Radiographers, you have MR responsible person, I think is what you call, and we have here in Portugal in some parts, in some hospitals, but it's not a legal role, let's say like this. But we are creating that in the consortium, the curriculum only. We are providing a basic course and an advanced course, and only radiographers and radiographers with that advanced course, with the roles and responsibilities of that advanced course will have, let's say like this, the MRI safety officer role for the hospital. But I think I don't want to say that we are going to have some issues because the universities want to create that role. There are universities that are involved in that consortium that has 6 or 7, and they are creating that role let's say, how can I say, because I am the clinical representative, I'm only a part of the model, of the scientific model of the advanced course. I'm not inside of the legal situation on that. But in terms of the to create a curriculum that will be a uniform curriculum from the European countries, all of the European countries, in terms of advanced role and responsibilities of the MRI safety officer. Of course, we have to have that in our institutions in Europe, the same as United States have, of course, because with that role, the MRS. So I think the policies inside the institution will be uniform, will be homogeneous, and creating that role with the country, like we say, the country's policy for regarding MRI safety. Because, for example, in our country, like you know, Sam, we don't have policies regarding MRI safety in our country. We are trying to make that. So I think it will be a fantastic achievement if that role in Europe will take into account in our institutions. And I think it will be fantastic not only to have the MRI responsible person, but because it's not a legal role, but with the MRI safety officer, like, for example, we have in our country a legal role for the ionizing radiation responsible person. We have that on the legal system, but the MRI safety officer, we don't have that. We don't have the MRI responsible person, but of course it is crucial because, like Erika said, when we have an accident in the MRI, we can have deaths, of course.
Yeah, I think it goes in tandem what Bill Faulkner was saying. It's what ABMRS is trying to achieve as well, which is the standardization of that knowledge, of that role. We have something like that in UK as well. Erika is probably more than aware of this. Of course, you've been involved in it as well. From what I know, and Bill was talking about ABMRS, and Manny also mentioned that on his presentation, ABMRS becoming kind of an international thing as well. I would love to see all of these countries getting together in this kind of standardization for the role of MRI safety officer, MRI safety technologist, and all of the other ones that we have. Erika, please go ahead. But this is something that I would love to see, standardization across the board and not just within the 50-something states in the United States or in the European countries and then UK, and all of us are doing something similar. Because I like to say that MRI safety is a universal language, but we all talking this language in a different way with a different accent, and I don't think we need that. We need to talk the same language with the same accent. So that's my view. But Erika, please go ahead.
Oh, sorry, I meant to put my hand down. Sorry, but yes, I think we're all speaking. Yes, it's about culture and it's about language, and I think where we've always had the trailblazer of, you know, Manny and the MBRS, the actual syllabus for the MRSO, that's a fantastic starting point for everyone. But I think going back to what Doug was saying in the first place, it's about culture. And one group of staff that we haven't actually mentioned tonight at all, which we rely on hugely in the UK, are our clinical scientists, our MR physicists. And we work collaboratively with them. So just as a model, I am so proud really of the way that the UK is embracing MR safety. We have e-learning that is national, that is and using the same language that we use in the MHRA guidelines that underpin our safety procedures. And then we work together within our trust. We work with anywhere that has an MRI scanner. So we have an MR scanner in our radiotherapy department. So we have a joint committee, we meet quarterly, and we have generic procedures that are evidence-based. So this is all about, you know, language and culture and working together. But ultimately, as Manny says, the patient does not belong to us. We can inform, we can educate, and we can support our clinicians, but at the end of the day, the risk is with them. And it's all about protecting our patients.
I'm extremely glad you mentioned this, Erika, especially about the clinical scientists, because we had a couple of them on our podcast. And I think their role is crucial, especially from a workflow perspective. They're not just looking after safety, but they look after protocol optimization, many things within a department. And again, we go back to the importance of the multidisciplinary team, because we might have different structures, different practice, slightly different roles, but ultimately we always find a way to work together collaboratively. Doug, do you want to add anything on this, maybe?
Just a quick, update. Erica, thank you for bringing up the medical physicist. I mean, they play such an important role for our departments. But Sam, I'm going to go, I'm going to add to yours. I mean, it's a dream of mine to just get everybody at the table, and sit and have one standard, to not just recommend or suggest, but to mandate. This is how we do it. Again, just my opinion. I would love to see that happen. And hopefully someone, or we can all as a I call us a family, set something up. I don't know if it's realistic or not, but yeah, I mean, pick a place. I would be there. And I know everybody in this room would probably be there as well. And we set the standards.
Doug, I tell you, Doug, we tried to do exactly that years and years ago, and it didn't happen. And as a result of that, we got together and created the ABMRS and said, if the established societies won't do it, we'll do it. Every established society has now bought into the ABMRS examinations, the standardization. The standardization for the positions came more than a year after we created the tests and started administering them. And the same thing is going to happen here. You don't wait for them. This is the expert. This is the body of the people in front of you. These are the type of people that have the experience. Erica, your statement about the physicists, it's a perfect example of where America has to grow and where America has to learn from Europe. It is not, the physicists in the United States, typically, there certainly are exceptions, have nothing to do with MRI, nothing. They're hired, they're retained because it's a mandate for ionizing radiation only. It's not their training, and we need to turn to our European colleagues and learn more about what they've done and see how successfully they've been integrated. We've appealed to them, and we're starting to see that there is more motion and movement in the societies from the physicists. We want them to take much more of an active role in the clinical care. We'll keep their liabilities. We said in the United States, we're willing to keep the liabilities. We just want their brains, their experience, their knowledge to help guide us. And exactly as has happened in Europe and in the UK, we use that as an example.
Perfect. There was actually a question here from John Carey. He was saying, sorry if I butcher your name, not my intention. He was saying, if you are an MRSO, either in US or in UK, would you be able to perform that same role when you move to a different country that does not recognize this qualification? So for example, in Portugal, we don't recognize that qualification. Vitor, you agree with that? So in UK, a few years back, I was the MRI safety officer for my institution, which was the biggest private healthcare institution in UK. I had that course done actually with Manny in 2016, and I was that person for my hospital, but it wasn't a recognized role yet in UK. So for a few years, I was the MRI safety officer, not in the paper, but in the actuality, I was performing those duties by informing my colleagues, my radiologists, for the safety of the implants that my patients had or not. Should I scan this? Should I not? I would inform my radiologist, explain to them why I would go ahead with a patient that had a pacemaker and they didn't want to scan him. So I was portraying that role even if it wasn't recognized. So I think this ABMRS announcement that Manny was mentioning on the 11th of December will be extremely important for this standardization, because we need this around the world, not just in US, not just in UK, not just in Portugal. We need it everywhere. We need this kind of standardized guidelines to be there for us to know what to follow. Because I'll give the example of Portugal once again, because it's my country. I've moved back to Portugal now, and I'm actually facing these realities where I go to a hospital and I ask them, what guidelines are you following? And some say, oh, I'm following MHRA from UK. And then I go to another hospital and they say, I'm following the ACR Manual for Safety 2024. And then I go to another hospital and say, we don't follow anything. We have our own guidelines. We have a training with Professor Vitor and we're following whatever he's saying. So
I would probably go for that one.
It's this kind of lack of uniformity that makes us feel so afraid of doing certain things. Most of the times we reject patients that would never be rejected, for example, in many scanners, or would never be rejected by Bill Faulkner. But we have those patients being rejected here on a daily basis because we don't have that knowledge, we don't have that standardization, and we don't have someone behind us saying, you're doing what you should be doing. So I think that's really important to touch upon. I had one question for I think Bill can answer this question as well, because we're talking about implants, we're talking about burns.
I think there is Toby that wanted to say something about that.
I'm sorry, Toby, I didn't see your hand there. Please go ahead, and then I'll ask my question.
So I just wanted to add to what you were saying about sort of the call for standardization. In the United States, there are some partnering organizations who are recognizing the MRSO credential, for example. But today, in 2025, it's not yet standard at hospitals. It's not yet mandated by the reimbursement programs and that sort of thing. So I'm of two minds. Number one, I'm overjoyed that you made reference to the States as being a place where this standard exists, because it is at the very early stages of existing as a standard, and it's not quite there yet. I'm overjoyed that you talked about the UK, and I know that, you know, there's NHS in the UK, and then there are private, you know, providers in the UK, and you know, what's standard in one enterprise may not be standard actually across the country. The lesson I want you to draw from this is that it is fundamentally up to us to define what the standard looks like tomorrow. And it is in many ways just a sheer force of will that we decide, we collectively sitting here decide, this is how we want practice to work relative to MRI safety. And then we just simply go out and we practice that way. And we tell everyone that we come into contact with, this is the way that we're practicing. This is the document we're using. These are the standards we're referencing. And it is that act that turns something into the quasi-standard, the grassroots revolution, into the clearly defined, widely accepted standard of practice. And we, if we are patient enough and we are bullheaded enough, and we work collaboratively with a common purpose, we will make all of these things the standards.
Yeah, I agree. Benny, please.
I love the point that Toby brought up, and Sam, I think everyone in this audience should recognize we're using the word standard as if it has a standard definition. In the United States, there are two standards. The American College of Radiology publishes what they refer to as practice standards. And you could look up for mammography, and you could look it up for interventional procedures, and it'll say these are the practice standards. There's a far more, in a sense, important standard. And that, in the United States, the Litigious Society, once again, that's referred to as the standard of care. And the standard of care means what a reasonably similarly trained professional would have been expected to do under those circumstances. And that's what runs our legal system. The ACR, the American College of Radiology, publishes the practice standards. And you can look up any of them. On the bottom, first page, on the bottom of every single practice standard for mammography, for venography, for everything you could possibly picture, every practice standard says, these are not intended to establish a standard of care. They are recommended guidelines that we believe are appropriate for the practice of musculoskeletal imaging. And the attorneys laugh out loud at the American College of Radiology, thinking that by saying they're not intended to be standards of care, that they in any way affect what happens in a courtroom. Because in a courtroom, they're going to hold them up and say, why didn't you do this?
Yeah.
So the bottom line is simply going to be, there's a saying in Hebrew, when there's no man present, be a man. If no one is out there establishing a standard, and you've tried, and you've asked, and you wanted cooperation, it didn't happen, then go out there and create it. The American Board of MR Safety was so called because the initial members were majority from the United States. We are in the process of changing our name officially to the International Board of MR Safety, which is from day one, go look at our website, the published intent on the day it was created was to be the International Board of MR Safety. On day one, 30% of our members were international, non-United States. And now we're finally at the point where we're imminently going to be changing our name, and the announcement will be coming whenever they're ready to make that announcement. And the intent, once again, is to wait for no one. If that's where the expertise is, gather the expertise internationally, arrive at consensus, publish them, and get out of the way. And then anything not reasonable, it'll be fed back into you. What are you talking about? How could you possibly do? You have to wear a green shirt, not a blue shirt. And it'll be self-correcting instantly, because nothing is more expert than the field. The people out there in the trenches actually doing the work every day, and they'll be the ultimate judge of what is and isn't a reasonable standard of care. So right now, we're about to see those standards change, and the Wild West that was remote MRI is nothing more than an overlap of the Wild West that is standard MRI. As Erica says, when you're not paying attention and major catastrophes still happen, we need a little bit more standardization in all of our practices, not just remote MRI.
Amazing.
Absolutely. Julian, I think we almost done. We have way more questions for everyone. But
I was just noticing, I think we answered almost 100 questions in the Q&A box, and I think we have been trying to answer the remaining 30, but it will be a little bit difficult.
We won't have time. Maybe in a future event we can do a whole day instead of just a few hours. But there's a question that I wanted to ask Bill. I would love to hear a little bit more about with you, Bill, because you're talking about burns and those kind of problems that we have on MR, which is the most reportable issue. It doesn't mean it's the most common, but it's the most reportable one. There was a comment about using super high fields like 7 Teslas, for example. What are your thoughts in terms of the challenges that we face regarding the magnetic field exposure, the implant compatibility, acoustic noise levels, burns? What are your views in terms of the direction that we're facing now with these 7 Teslas, 11 Teslas? There's even a 14 Tesla being built in Germany. What's your thoughts on that?
Well, that's highly above my pay grade. A man's got to know his limitations, and I mean, I'm not one to make stuff up. Actually, I do know that currently, at least in the U.S., and I know it's based on some meetings I've been to. Right now, the 7 Tesla is kind of limited to head and extremity, and I know the 11 Tesla that they have in France is also head only. The challenge is actually scanning in it, because of the frequency and field uniformity. I mean, there's all kinds of scientific challenges that make me glad I'm about to retire. So, it's interesting though, when I started in MR back in 1985, 1.5 Tesla, Manny was there same time. 1.5 Tesla was a big freaking deal. It was like, doctor, you don't want a 1.5 Tesla. There's all kinds of problems with implants and devices. And they got this thing called chemical shift. Doctor, do you even know what chemical shift is? And, you know, it'll only be in research institutes and all that kind of stuff. And, you know, they're saying the same thing about 3T and saying the same about 7 Tesla. You know, technology advances, but there are some challenges, certainly. And it would be interesting to see what those challenges might be.
Yeah, I think it's going to be very interesting times coming up, not only with the high fields, but with the low fields as well, with the advance of AI as well. We kind of have...
I can tell you, low field's making a great comeback with all the artificial intelligence. There's a big benefits at low field. I was reading articles the other day about lung imaging. Saw something on children with certain lung diseases and looking at them at low field. I know for, you know, with patients with metal artifacts and things like that, you know, you're less sensitive to susceptibility. That's a good thing, but it can be a limiting thing if you're looking for susceptibility, which is why higher field, right? Which is why higher field pays off, because you're more sensitive in functional MRI imaging. Higher field also gives you the ability to do things like phosphorus, sodium, you know, look at other magnetically active nuclei. But the low field, even the very, you know, the 0.64 Tesla little portable systems with the artificial intelligence, you know, it's actually much better than what we were doing in 1985 in some cases. So, you know, I think our technology is just, you know, just waiting to boom.
Yeah, I think that's you touched 2 points that they are perfect. One of them is back then, though, those fields didn't look as they look today. And we actually, on our documentary with Siemens, we will talk about that. We will show.
I remember a talk I saw where some guy who worked for GE back in the day, when they first did their first 1.5 Tesla scan to put out at RSNA, and they were working through the night feverishly to get this scan on a 1.5 so they could put it out there and go, look, we did it. And, you know,
that's
come a long way.
Good story, and we'll have another story similar to that, which involves some beer as well, while waiting for T2 to finish. So that story will be on the documentary as well. Doug, before passing to you, there's another thing that Bill was saying with the low fields. One of the things is we are already providing healthcare to rural areas and unprivileged areas as well, not only with these low field scanners, but with remote as well. So we actually double down on the remote, because we're using remote operations with low fields in rural areas to give access, to democratize access to healthcare, which I believe it's something that we all should strive for, because at the end of the day, as Manny is saying, what we're discussing here is the patient. And that's one of the best things that we can do. But Doug, please go ahead. After your intervention, we go to the final remarks. So
yeah, no, just real quick, just wanted to add a little bit on the 7T, just because I know of a center where they're burning up head coils and knee coils like it's no tomorrow. So that scares me a little bit, but we'll see if they get that figured out.
Is that a research center, or what's going on there?
No, they're actually scanning patients. So
okay,
it is a research. It is part of a research center, but yeah.
Sam, you should be aware that 7T, I like to say 7T is not just a big 3T. The real area in which I believe it's a concern that a practical radiographer should be aware of is resonant circuitry. The idea that the resonant lengths at 1.5 Tesla are ballpark about 30 centimeters or so. At 3 Tesla, you're talking 12, 13 centimeters for a linear structure. But if you're talking 7 Tesla, you're talking 5, 6, 7 centimeters. I have patients with aneurysm clips of that length. So what we need to recognize that once you get to 7T, implants that we would never be concerned about thermal safety, now we have to at least start thinking about resonant conditions being satisfied potentially. And the right orientation with that much power and that wavelength, I go back to it over and over again. 7T is not just a big 3T. Not when it comes to the number of humans that have 5 centimeters implants within them is not trivial. The number of humans that have 30 centimeter implants by comparison is an order of magnitude fewer. So just keep that in mind before you go to 17 and start thinking you can scan them with foreign bodies and what have you. It's a different matter entirely.
You could get people with coronary artery implants if they have, stents, if they've got a full metal jacket, as we call it. That's getting close to it.
It's a different ball game for sure, and I don't think there's enough awareness and knowledge about it yet. But Doug just told us that they're burning coil, so I can't even imagine what they're doing to patients, which scares me a little bit. Before I just want to basically thank you all. I think I will give you the chance to do your final remarks. I will do mine first, as usual. I just want to thank you all for being here. And when I say all, is the speakers, Julian, of course, and all the attendees that stayed for how many hours we've been here. We still have 230 people waiting and listening to us yapping about MRI, because we all love MRI. We are so passionate about that we could be here hours and hours. It's 11 p.m. where I am. Midnight where you are, Julian, I guess?
Yeah, well, I think it's midnight. Well, midnight right now, on the dot. Perfect timing.
So once again, thank you so much. Apologies for the quality of the lectures. That's on us, and I want to make that clear. So it's not on the speakers. So it was a technical issue from our side. So apologies once again. And the whole objective of this event and what we do is everything MRI is to bring the community together and improve what we're doing on a day-to-day basis. That's why we're building the academy. That's why we're doing these events, the documentaries, and all the other material that we do for free is to empower you to do your jobs better and to empower you to come to these events and speak your mind, ask your questions, and you do your own webinars, do your own presentations, put yourself out there and show to the world what you know, because as many has said as well, we are the ones that know the most about MR, and we shouldn't be afraid to speak up. So from the bottom of my heart, thank you everyone that is here, including Julian, of course. And I'll pass to each one of you. Julian, maybe you want to start and then we'll go one by one.
I just want to mention very quickly that each of the speakers that talked today came to join this conversation completely for free. And I think that is another thing to mention, that they renewed, their trust on us. Every year, some of them, as we said, have been here from the very first day, and every time they come here to share their knowledge completely for free. So I would say I'm very grateful for that, because every time personally I learn a lot, and whoever joins, I think, is always like a sort of like master class we provide. So thank you so much for doing that, and with I would say a huge extent of generosity from your side.
Should we start by Erica? Do you want to have any final remarks?
Just to say thank you very much. I love what you're doing. It's been an absolute pleasure. Thank you very much. I've really enjoyed it.
Thank you so much, Erica. Should we go in order? Doug, do you want to say anything? Sell your book. We already put the correct code. I hope everyone has it. So let's hope this time it works.
No, thank you guys. It's just, as an educator, I love education, and just you guys providing this for the industry is awesome. So thank you, and thank you for all the other speakers that are in the room. It's a joy and an honor being part of it.
Thank you. I'll go in order of who's on my screen, so it's nothing personal, guys. So Vitor, would you like to say anything to close today?
Thank you very much for the opportunity, and we want to say that Sam and Julian keep on the good way. This is the way that we perform and we contribute to the collaboration and the shared responsibility in MRI safety and other stuff in MRI, like you will do in these courses that we show, and the next courses that you want to share with the MRI community. Thank you.
You can say we, because I want to have you on it. So, Toby, please.
I'm going to echo something that I think Doug began to say, and that is, I want to applaud you, Everything MRI. There are standards bodies that represent the interests of industry. There are standard bodies that represent the interest of regulatory authorities. And I think what what this meeting is doing, what everything MRI is doing, is sort of building a body of radiographers and people who have sort of direct frontline responsibility for MRI safety, and creating a community and a body of standards around safe delivery of care to our patients. And for that, thank you.
Thank you, Thomas. Bill, you're the next in line on my screen, at least.
Okay. Well, thank you all very much for the opportunity to be on again. It's always a great honor and a pleasure, and look forward to next time if you'll have me. Thank you.
Thank you. Manny.
The only message I'd like to leave to everyone is there's a book in the United States, The Little Engine That Could. It's about an engine that tries to go uphill, and it can't do it, it can't do it, it can't do it. But it said, yeah, it could, and it eventually did. To all the people that are brave enough to still be listening, you are the industry. Everyone is catering to you. If there's something that you want, don't be afraid to gather, get your thoughts together, represent yourselves collectively. Everything MRI, I keep saying this to you, Sam and Julian, you are to be commended for your efforts. Why everyone here is volunteering to help you, because you are creating the body of end users that will not be left out and that will say, this is what we think is reasonable and not reasonable. They want education, they want to know what to do, and they want it to be practical. So don't be afraid to get together, voice your opinions. If you disagree with things you've heard tonight, don't just let it go. Feed it back. That's what they wanted. We want active discussion, active participation. 𝐂𝐐𝐫 has created the MR Safety Facebook page in the United States. He started in that setting, and with 30,000+ people, this is a voice to be reckoned with. Add your voices to that one collective end user voice. Speak to regulatory, speak to the manufacturers, tell them what you want and what you think is needed. I'm telling you, you can. And it's because of you that the industry exists in the first place. So don't be afraid to get together. Don't be afraid to give your opinion. Participate in meetings such as these. Give your feedback and speak up. It's better for your patients. It's better for society. And Sam and Julian, thank you again. And all the other speakers, thank you all of us. Thank you for your time. Thank you all for your attention and for your involvement.
Thank you. Before we go, just to say that the recording will be available, Julian, 1 week. That's
Yeah,
it.
even less. I will be working on it tomorrow.
Okay, perfect.
Sorry.
So it'll be online for everyone to rewatch it if you are that kind of MRI geek like we are. So I'll probably watch it next week again. And certificates will be sent within 1 week, 1.5 weeks. Please be aware that it's just me and Julian behind everything MRI. We are 2 people. So it's not easy to do all of it. So the certificates will take a little bit longer. So bear with us. We'll send them. Certificates of attendance to everyone that were here. I think around 500 people in general. So once again, thank you so much. Enjoy the rest of your day, evening, night, whatever it is. And to you guys, once again, thank you so much for taking so many hours of your time to be here and support everyone in this journey that we all love so much. So once again, thank you from the bottom of my heart, and see you soon.
Thank you.
Thanks,
Cheers,
guys.
everyone.
Take care.
Bye-bye.